A very good morning to all the audience. Welcome to the Sport Emergency webinar series 1. I'm Elston Chong. I'm the host for today's webinar. We are very honored to have many distinguished guests and speakers for today's webinar. So I would like to welcome our moderator for today, Associate Professor Dr. Zulkarnain Jaafar. He is the senior lecturer and also the consultant sport physicians in University Malaya Medical Center. And I would like to pass the following time to Prof. Zul. Welcome, Prof. Zul.
Right, thank you very much, Dr. Elston Chong. All right. Assalamualaikum warahmatullahi wabarakatuh and salam sejahtera. Good morning, everyone. How is everyone doing? I hope that all of you are doing fine and stay safe. I also hope that you already had a good breakfast, or else you can grab your coffee or tea while staying with us. Again, I would like to welcome all of the participants to the Sports Emergency Webinar Series organized by Sports Medicine Unit, Faculty of Medicine, University of Malaya, together with Malaysia Association of Sports Medicine and Sports and Exercise Medicine Research and Education Group, University of Malaya. Thank you very much for making yourself free this weekend and spend your time for today's event. I hope that this webinar will be beneficial and will provide us with the useful knowledge and input. This Sports Emergency webinar series is actually a 3-series webinar focusing on injuries and emergencies related to sports activities. We have invited experts from various fields to give their input throughout these 3 webinars. These webinars are aimed at sharing specific and updated knowledge on emergency that could occur during physical and sports activities. And we would also like to wish to connect all professionals in various disciplines with the sports medicine team. Before we start, I would like to inform everyone of a few housekeeping information. Okay, firstly, all of you will be muted upon entering the webinar in order to avoid any interferences during this session. This webinar will be aired on Zoom platform and also will be live streamed on Malaysian Association of Sports Medicine Facebook page. This session will be recorded and shared after the webinar has ended, and you may rewatch this webinar on YouTube platform if you have missed any information or you want to revisit the topic discussed here today. Also, if you experience any technical difficulties, do write your issue in the chat box. We will try to solve the problems as soon as possible. And again, if you also have questions to our experts, do write your question in the Q&A box. We will try to answer your questions after the speaker has given his or her presentation. And finally, for medical practitioners who wish to collect CPD points, 3 CPD points will be awarded, and a QR code will be shared at the end of this webinar session. And I hope that you will stay with us until the webinar comes to its end. Okay, to start off with this session, I would like to call upon Associate Professor Dr. Muhammad Naha Azmi bin Muhammad, the Head of Sports Medicine Unit, University of Malaya, to give his welcoming remarks. You're welcome.
Thank you, Prof. Zul. Assalamualaikum warahmatullahi wabarakatuh. A very good morning to everybody. How's everybody today? I hope everybody is in good health and stay safe always, yeah? I'm privileged to be involved in this. Very beginning, I would like to welcome everyone, and also what I would like to address my honor and privilege because we have a very well-known speaker from different disciplines. I would like to welcome also Prof. Jaya, Prof. Jacob, and also Prof. Rashidi. So the reason why we have this series, we would like to enlighten everybody to the current knowledge on how to manage sports emergencies during sports coverage or any form of physical activity. So I'm sure for today's series, we have an expert from ENT, from dental, and also from emergency itself. So we may learn something might we have not encountered before. So hopefully this will be enlightened to everybody. So again, thank you so much everybody for joining us for our first series, and hope you will join us until the end, and also the next series number 2 and series number 3. And then again, thank you Prof. Jaya, Prof. Jacob, and also Prof. Rashidi for your time spending with us throughout half a day for today. So it's 3 hours. It's quite a long half day for us. Yeah. Thank you so much. And again, to everybody, do enjoy and listening. If you have any question, do ask to our expert. And we together also would like to enlighten and enrich our knowledge from the various disciplines for this topic for today. Thank you so much and do enjoy the talk. Thank you.
All right. Thank you very much, Prof. Naha, for your supporting notes. For today's webinar, I'm very delighted to have 3 experts with us who will be talking about sports emergency in relation to their fields. First, we have Associate Professor Dr. Jacob John Chiramal Chandi, Professor Dr. Rashidi Ahmad, and Associate Professor Dr. Jayanti Kulasegara. All right. To begin with our first topic, that is dental emergency in sport, our expert today is Associate Professor Dr. Jacob John. He is a consultant prosthodontist in the Department of Restorative Dentistry, Faculty of Dentistry, University of Malaya. He graduated as a dental surgeon from the Tamil Nadu Dr. MGR Medical University, India in 1994, and subsequently qualified as prosthodontist from the Kuwempu University, India in 1997. And he joined University of Malaya in 2009. Dr. Jacob has been actively involved in research, collaborating with fellow researchers both within Malaysia and globally. His main research interest lies in the field of prosthodontics, geriatric dentistry, and dental education. He has so far supervised more than 10 students at master and PhD level. He has published over 30 papers in peer-reviewed international journals and contributed chapters in 4 textbooks. He has also presented his work at many international conferences. He is a life member of the Indian Prosthodontic Society, founding secretary of the Malaysia Association of Prosthodontics, and currently the honorary secretary of the Asian Academy of Prosthodontics. Apart from that, he is also a member of the International Association for Disability and Oral Health since 2011 and works very closely with the Special Olympic Malaysia in providing oral health education and care for the intellectually disabled community. I would like to welcome Prof. Jacob to give his talk. The mic is yours, Prof. Jacob.
Thank you, Prof. Zol, and very good morning to all. Let me start by sharing my slides. Oh, sorry. Can you see my slides? Sorry.
Okay.
Okay, are we on?
All right.
Okay, thank you, and sorry for the glitch. First of all, a very good morning to all participants for this first series of webinars presented by the Malaysian Association for Sports Medicine in collaboration with the Sports Medicine Unit of the Faculty of Medicine and SEMREC. And I'm thankful to the organizers for inviting me to share a little bit of what I know about the dental emergencies, which is related to sports medicine. And I hope this sharing will be of some benefit to the audience, because I know most of you are in the medical field, and probably the oral cavity probably is hidden by the lips, and you may not be very aware that it also has a big role to play in the outcome of one's sports contribution. And hopefully it enlightens you by the end of my talk today. Now, let me start off with my journey with sports medicine. We have got the opportunity to recently do a small collaboration with the MSM and our sports unit headed by Dr. Sharif in our team. And this is what I would like to show you. This is the inside picture of the mouth of some of the athletes that we had surveyed on during our study. And I consider that you would agree with me that this is not a very good picture, and this can cause a lot of hindrance in their performance in the end, and which can be solved by having a good oral health knowledge, as well as interventions at the appropriate time. Now, I will be sharing with you on some of the common emergencies that you can encounter, which will include in the soft tissue area. Then we go into the mouth, where the dental pain, post-extraction problems, fractures on the tooth or the crown, avulsion, what is avulsion, intrusion and extrusion, and we will look at a little bit of the maxillofacial traumas, and what are the how do you prevent them, and what are the emergency care that you need to provide. So let's start with the soft tissue injuries. Okay, we all know that face is the most exposed part of the body. Okay, in any sports for that matter, and injuries to the soft tissue of the face are very frequent. Okay, I'm sure many of you will agree with me. Abrasions and lacerations. Okay, you're very familiar with these terms. Okay, and they are common and should be evaluated to rule out fracture or any significant underlying injury, because sometimes we just push it off saying that it's just an aberration, but it could lead to further damage also because of that encounter that the person had had. Now, these usually occur over a bony prominence of the face skeleton, especially around the brow, the cheek, and the chin. Now, lip lacerations are also very common. So these are the soft tissue injuries that normally you can encounter during a sports event. Going to the next part, which is the dental pain, or where I showed you just now that the anatomy of the tooth. I'm sure all of you are familiar with that. And what is important that for us to know is that the tooth is composed of many different compositions. Okay, it is starting off with the enamel. Then you have the dentin, and the dentin is what is covering the pulp chamber. Okay, which is the nerves and the blood supply to the tooth, and that is connected on to the adjacent teeth, as well as supported by the gums and the periodontium. So now the first dental pain that is mostly encountered is known as the pulpal pain. Okay, this pulpal pain is a very spontaneous, strong, and often throbbing experience, and it can be exacerbated by temperature and it can outlast the evoking stimulus. Okay, so these are salient features of the pulpal pain. It can be localization is poor, and the pain tends to radiate toward the ipsilateral, same side, ear, temple, and the cheek. The pain may reduce spontaneously, but the patient should still be referred for dental advice, as the pulp has probably necrosed, and acute periapical periodontitis, which is also known as the dental abscess, will probably follow in due course. Okay, it may come and go off, and you may think that it was a one-off activity, but be assured that it can recur again. Because if you see the diagram that I've shown, that cavity that has happened in the occlusal surface, or the biting surface of the tooth, has spread to the level of the pulp, and that is why this pulpal pain has occurred. Now the treatment is, okay, from the dental point of view, it is endodontics or root canal treatment, or otherwise known as root canal treatment, which can still save the tooth. Okay, if you want to know what is root canal treatment, now you see that this diagram, it has got I told you it is the pulp chamber. So in the pulp chamber, you have the blood vessels and the nerves that is supplying that particular tooth. Now, because the tooth is affected by the caries to a large extent, that nerve and the blood vessel has to be removed from the tooth. So technically, the tooth becomes non-vital, or you can call it a dead tooth. But the structure of the tooth can be still retained. You do not have to go to the extreme solution of removing the tooth. So that is what we do in endodontics, or what you call the root canal treatment. So, but if this is not possible due to the circumstances of the situation, then you will have to go for an extraction of the tooth or removal of the tooth. Now, dental pain can also come about as a periapical periodontitis. Okay, you know, periapical means it's at the bottom of the apices of the tooth, and it also involves the periodontium, that is outside the tooth, the region outside the tooth in the bone of the oral cavity. Okay, so that is why it is called periapical periodontitis. This can be spontaneous and severe, can persist for hours. It can be well localized and exacerbated by the biting force. When you bite, you can feel that pain increasing. The adjacent gum is often tender to palpation, and abscess may form. Okay, like you see here in the diagram down here, you can see the periapical abscess. Sometimes with facial swelling, to the extent of having a facial swelling, okay, where you call it a cellulitis, fever, and illness. Okay, so this is more serious than what we had seen earlier. Okay, the facial space infections are fortunately rare, but since they threaten the airway, patients should be referred to a specialist. Okay, again, do not wait till it is come to this stage. That is what is important. Okay, the treatment in the absence. Now, if you're not able to assess to immediate dental attention, best to incise the fluctuant abscess and give antimicrobials and analgesics. And acute stimulation usually then resolves. Okay, the immediate affected it resolves, but the abscess will recur, since the necrotic pulp will become reinfected unless the tooth is, like I told you earlier, endodontically treated, or it is the tooth is removed. Though the chronic abscess may be asymptomatic apart from a discharging sinus. Okay, so these are things that you have to remember. It may be just asymptomatic, but it is boiling down there, and it can suddenly erupt. Okay, just like a volcano, it can suddenly erupt, and it is a nightmare. Okay, so fortunately, rarely this may be open into the skin. Okay, it rarely happens, but it can also happen. Okay, so that we have to be aware of. Now, from dental pain, we go to post-extraction complications. Okay, so Post-extraction means after the removal of the tooth. Some of the emergencies that can occur will include a bleeding. Now, after a tooth is extracted, the socket bleeds normally. It is normal for the socket to bleed for a few minutes, but then it clots. Okay, there the healing process starts. Now, since the clots are easily disturbed, patients should be advised not to, okay, these are the things that they have to take into consideration, not to rinse the mouth, not to disturb the clot, don't chew hard, take hot drinks or alcohol, or exercise for the next 24 hours. Okay, this probably is something that you have to remember. After the removal of the tooth, try not to exercise, okay, especially for coaches who are here, the athletes who are here. Do not try to do any strenuous activity, at least for the next 24 hours after the extraction is done. If the socket continues to bleed, now pack. Okay, this is what you can do before you seek the dental advice or dental care. So you pack that area with gauze across the socket and ask the patient to bite on it for 15 to 30 minutes. Okay, this in normal circumstances, this if it was that clotting had been disturbed, it will reclot and then the bleeding will stop. If the bleeding still continues, then you can place something called Surgicel or any hemostatic agent into the socket. Again, if the bleeding continues, the socket need to be sutured. Okay, this then you will have to go to the dentist to get that care. Now, if it is still going on, then you have to suspect unrecognized bleeding tendencies on the person and seek further investigation. Okay, so this is with regards to bleeding after the extraction of a tooth. Next, we look at infections that can occur after the extraction. Okay, this is known as the dry socket or localized osteitis, and occasionally it follows an extraction, typically in the lower molar extraction, after the lower molar extraction, typically after the lower molar, but does not have to be conformed to the lower molars. Okay, so after 2 or 4 days, there is usually increasing in the pain. There is halitosis, okay, bad breath, unpleasant taste in the mouth, and empty socket and tenderness in that area. Okay, so these are symptoms that you will have to identify probably or relate to post-extraction infection. But you have to exclude retained roots, foreign bodies, jaw fracture, osteomyelitis, or other pathologies. Okay, these can also sometimes mimic these symptoms that I had explained to you earlier. Okay, especially if there is fever, intense pain, or neurological signs like labial anesthesia still persisting, even though the extraction was done sometime earlier. Okay, so what is the treatment for this? Treat by what we normally do is treat by irrigating the socket with warm saline or chlorhexidine, dress the socket, and give analgesic or antimicrobial. This instance, we would prefer to give a metronidazole. Okay, and actinomycosis is a rare late complication of extraction or jaw fracture, and usually it presents as a chronic purplish swelling. For this, the treatment would be a 3-week course of penicillin. Okay, but I'm sure the medical colleagues will know what will be the best way to handle this situation. Now we go to the fracture of crowns and roots. Okay, when one takes a blow on the face, it could result in a cracked or a fractured tooth. Okay, we are all aware of this. Now, crowns are fractured are the most common injury to the permanent dentition, crown fractures. It is more seen in the younger age, okay, but one of the most prominently seen emergency in dental care is in sports dentistry is fracture of the crown. Okay, and when the tooth is cracked, one might experience symptoms like sharp pain when you bite down, tooth pain that comes and goes but isn't always present, or pain while eating and drinking, especially when you consume hot or cold food. Okay, again, these are symptoms that you can relate to fracture or crack of the tooth. Now, enamel fracture, it needs no emergency care, but dental attention should be sought later, okay, because it can, worst scenario in that is causing of sensitivity of the tooth, okay. It may not exacerbate, but it is better to get a dental attention sometime after that incident has occurred. Now, injuries affecting the dentin, it should be treated as urgent, as there might be pulpal infection. I showed you the anatomy of the tooth just now, so you have a good picture where the dentin lies, where the enamel and the dentin lies, and how close the dentin is to the pulp chamber. So that is why it is an emergency care of this. It will consist of placing a suitable dentin lining. Okay, this is again done in the dental, under the dental supervision, dental lining material onto the fractured dentin, and so prompt treatment is required. Okay, because here then the sensitivity of the pain is more exacerbated. Fractured roots require dental advice. Okay, and how do you, what is the sign of a fractured root? It is a mobility of that particular tooth. After the trauma, there is a mobility, then you can suspect fracture of the root as well. Another emergency that we often can encounter in sports activities is tooth avulsion. Okay, this normally the tooth that is avulsed can be replanted successfully if the root apex is not completely formed. Okay, but this disclaimer is there that the tooth root apex, normally of all the teeth, we have a maximum of 32 teeth in our mouth, and the latest will be tooth to erupt is the third molar, or the wisdom tooth that we call, and even that, the longest period that you would encounter that tooth to root of that apex of that tooth to be formed is 25 years, 17 to 25 years. So beyond that, probably the root apex is already completely formed. So the success rate of replanting the avulsed tooth becomes reduces. Okay, the prognosis also will be reduced. So if it was on a young athlete, the chances of the good prognosis is higher. Now, immediate replantation gives the best results. Now, just in case we encounter a situation like this, what should we do? Now, hold the tooth by the crown. Do not handle the root, as this can damage the periodontal ligament. Okay, like I told you, this is the live wire. That portion of the tooth is the live wire into the rest of the oral cavity. So if you handle that area, then you are damaging the periodontal ligament, and again the success of the replantation of the tooth will minimize. Okay, so first hold the tooth by the crown. If the tooth is contaminated, rinse with sterile saline, and if the socket contains a clot, remove it with saline irrigation. Okay, so you have to check the socket as well. If it is containing clots, remove it and then replant the tooth in the right way. Now, again, replanting the tooth in the right way is also very important, because you know the tooth has got 5 surfaces. Okay, the labial, lingual, mesial, distal, as well as the biting surface. So if you place it in the wrong way, again, the success of the replantation will be jeopardized. So again, replacing it properly into the right position is also very important. So one rule of thumb will be probably to ensure that the labial surface is facing forward. Okay, but again, it is easier said than done, because it will be difficult for a lay person. It may be difficult for them to identify which is the labial surface. Okay, probably the anterior teeth should be more manageable, but as you go to the posterior teeth, it will be more difficult for you to distinguish between the labial and the lingual or palatal surface of this tooth. Okay, so you may need, it will be more advisable to take the person as well as the tooth. Don't just bring the tooth alone, or bring the person but not the tooth to the dentist, so that you will be able to, they will be able to help in a more professional way. Okay, so once you have replanted the tooth in it, you can manually compress the socket and splint the tooth. The tooth has to be splinted, and make sure the patient sees the dentist within the next 72 hours. Okay, so this is if it is being done by a lay person. If immediately replantation is not possible, then you can also still preserve the tooth by doing the following. Okay, you can place the tooth in an isotonic fluid or a cool, such as cool, fresh, pasteurized or long life milk, or in saline, or maybe even in contact lens fluid. Okay, bring it in that solution, and the patient, if the patient is cooperative, okay, you don't have these isotonic fluids, but patient is also very cooperative, then you can place the tooth in the buccal sulcus and get the patient, transfer the patient to the dentist within the next 30 minutes. Okay, keep it under the tongue, so that is the saliva, and that way also you can transport the patient and the tooth to the dentist. Now, splinting tooth, just what I told you, you need to splint the tooth. It has to be splinted for at least 7 to 14 days. And during the stage, do not bite on the splintered tooth, have soft diet and good oral hygiene. And if necessary, you can even prolong it beyond the 14 days. Root resorption, ankylosis, tooth submergence, these are all potential complications of an avulsed tooth. In addition to ours, you can also encounter tooth intrusion. Okay. So in sports injuries, it is usually associated with teeth getting knocked out, but some injuries can drive the tooth back into the jaw. Okay, so it is pushed. If you see the diagram there, you can, it is clearer that the tooth is being pushed beyond the socket. It is gone upwards, and it's more common in baby teeth, because in child's alveolar bone, which hold the tooth socket, it is not as hard as the adult. Okay, so it is more spongy at that time, so it is more possible to occur when you have your primary teeth or the baby teeth. However, it can happen to athletes, and it's not that it's never happened in athletes, and it can happen at any age also. Some of the complications arising from tooth intrusion would include destruction of the tooth pulp, either by it dying or this necrosis taking place, or being damaged beyond recovery during the injury incident. Okay. Also, root resorption or shortening of the roots can take place, or ankylosis, a fusion of the injured tooth through to the alveolar bone. Okay, so these are all complications that can arise due to this tooth intrusion. Okay, just like intrusion, it can also extrude. Okay, this is the other way of looking at it. It is not pushed in; it is pulled out. So the tooth is displaced partially out of the socket and is usually displaced palatally. Okay, into the oral cavity. Okay, not pushed out; it is pushed in, depending on the trauma that take place. And what is the treatment? Repositioning of, just like avulsed tooth, repositioning of the tooth gently. Check the occlusion. Okay, this is important. Check the occlusion to be sure there is no pressure on the tooth, because if the tooth is still even slightly extruded, the contact between the upper and lower teeth on all the other teeth will be lost, because there will be an initial contact on this extruded tooth, hindering the contact between all the other teeth. Okay, that will again, if the tooth heals in that position, that will again cause a lot of problem for the recovery of the injury. Dentists will periodically monitor the vitality of the pulp and perform root canal treatment. Again, now you're familiar with root canal treatment, so root canal treatment will be another option of managing if need be at a later stage. Now, the last part of the emergencies would be the maxillofacial trauma. Okay, the simplest one, dislocation or subluxation of the mandible. Okay, it's commonly caused by a blow to the chin when the jaw is open, and the condyles are dislocated forwards and upwards. Okay, anterior to the eminence, and the patient gags open. Patient cannot close the mouth, or there is no occlusion between the upper and lower teeth. That is lost because the jaw is moved forward. the fractures must be excluded. Okay, first of all, make sure that it is not a fracture, but it's a dislocation or a subluxation. The reduction can usually be achieved, okay, by facing the patient, okay, stand in front of the patient, placing the thumb pads over the lower molars and applying downward pressure, and simultaneously the fingers under the chin, rotating the jaw backwards and upwards. Okay, so you are repositioning the mandible into the joint. If muscle spasm prevents reduction, then you may have to inject an IV midazolam in that situation. And after reduction, when opening of the jaw should be avoided, okay, because if the person again tries to open wide, the dislocation or subluxation can recur. Okay, so this is if there is a dislocation or a subluxation of the mandible. The more serious is the jaw fracture, mainly results from high velocity impact. Okay, and you normally encounter this in the road traffic accidents or other accidents, assaults, sometimes by sports impact. Okay, so that is why it is important for you to know about this also. It can happen among our athletes during the sports activity. So the immediate concern will be to preserve the airway. I'm sure after this you're going to hear more about this. So access the patient along the lines of the advanced. Okay, this is not my area of specialization, but just to inform you. So this is what you have to do: access the patient along the lines of the advanced trauma life support scheme. Other immediate life-threatening problems include intracranial hemorrhage, severe hemorrhage from other sides, and cervical spine damage. So these can also happen at the point of this trauma. Now, during the secondary survey, inspect the head for laceration and leakage of cerebrospinal fluid. Okay, but I'm sure all of you are more aware of these things. The associated bleeding may further compromise the airway. So jaw fractures alone, unless associated with the split palate, okay, within the mouth, the palate is split, rarely cause severe hemorrhage. The bleeding from a ruptured inferior dental artery usually stops spontaneously, but may recur if there is traction of the mandible. Okay, so this is a more extreme injury that can happen during the sports activity, and you need to get immediate attention. Okay, diagnosis of a fracture is from the history: pain, swelling, bruising, bleeding, mobility of the fragments, deranged occlusion, paresthesia or anesthesia of the nerves involved, and a radiographic proof. Okay, and what is the definitive management of fractures? Despite frighteningly severe disfigurement, it is not an immediate priority, but debris should be such as the fractured tooth or teeth, blood and saliva should be cleared from the mouth, and tongue may be controlled by a dorsal suture. Okay, so you can to an extent, okay, you can delay the management of the fracture, but make sure these things are cleared off from the airway. And oropharyngeal airway may be required, involving the maxillofacial team early on for treatment planning. And intubation may be necessary in presence of substantial head injury, and inability to intubate may necessitate surgical cricothyroidectomy, since nasotracheal intubation is contraindicated. Okay, this again will need the surgeon in the scenario. So in short, this is what you can expect dental emergencies that can happen. Okay, reversible pulpitis, irreversible pulpitis, abscess, cellulitis. Pericoronitis is where the gums are partially covering the tooth. Okay, this usually happens in the wisdom tooth, third molars, and it is usually occurring between the age of 17 and 25. Okay, because this is the time when the tooth is erupting, the third molar tooth is erupting, and in case there is not enough space. Okay, now what we have seen in the literature is with the evolution, the jaw seems to be reducing in size, and the number of teeth is still the same. Okay, so and when our good friend the wisdom tooth comes out, he does not have space to properly align with the rest of the teeth, so it comes in a crooked way, and invariably it will encounter an impacted situation. Okay, and if part of the tooth crown is visible and part of it is covered by the gums, then this is what you can encounter, pericoronitis. Okay, I'm emphasizing more on this because this is something again that you can relate with your athletes when they, especially in, like I told you, between this age of 17 and 25, when they complain of uncomfortable feeling in the tooth at the extreme side. It can be the upper or more common in the lower, on both right or left. Okay, it can happen simultaneously or it can happen in one of the quadrants. Okay, so you can suspect pericoronitis, and if it is not resolving, okay, by the normal irrigation antibiotics, then you may have to plan on removing the tooth. So again, this is another big area of discussion, and if you want to see whether what is the management of pericoronitis, but to avoid damaging the adjacent tooth as well as recurrence of the problem, then you may have to remove that tooth. And removing an impacted third molar is a surgical procedure which will have its own course of healing, with unlike the normal extractions. Okay, we also saw just now tooth fracture, tooth luxation, as well as tooth avulsion. Now, what are the dental indications for urgent admission to the hospital? First one, as you all would agree with me, is a trauma. Okay, it can be midfacial third fracture. It can be mandibular fractures unless simple or undisplaced, or it can be a zygomatic fracture where there is danger of ocular damage. Okay, immediate hospital admission. Next one is the inflammatory lesions and infections. Cervical or facial space infections. Okay, I told you about cellulitis just now. Oral infections where patient is toxic or severely immunocompromised. Severe viral infections or severe vesicular bullous disorders like pemphigus, Stevens-Johnson syndrome, toxic epidermal necrolysis. Okay, so these situations also will require the patient to be admitted for further management. Another situation where you need urgent admission will be blood loss. We spoke about blood loss just now. So the last stage of blood loss where you are not able to still stop the bleeding of the extraction or it's persistent hemorrhage, then you may have to suspect that there is a bleeding tendency in the person. Okay, that may be manifested for the first time through the extraction. Okay, so you may have to do further investigation to rule out blood disorders. Now, we have looked at all the emergencies, and now we will look at what are the best way of protection. Okay, I'm sure many of you would agree with me that mouth guard is a must. Okay, but unfortunately, we still haven't come to the culture of having it as part of our sports gear. Okay, players who don't wear mouth guards are 60 times more likely to damage their teeth during competition. Okay, 60 times more likely. And mouth guard is a must when playing any sports involving the bat, ball, stick, or person-to-person contact. A typical mouth guard covers the top portion of the teeth. Okay, I'll show you a picture of a mouth guard later. Many of you would have already encountered it, and they're designed to guard against the cut lips, broken teeth, as well as any type of damage to the mouth. Okay, and there are three types of mouth guards. One is called the stock mouth guard, then you have the boil and bite, and the last one is the custom made mouth guard. Stock mouth guard, it is readily available in the shop. You just buy and put it on, but it may not fit properly into your mouth, and it may not be as comfortable as the other two. Now, boil and bite, just like what it says, boil and then bite. So this type of guard is precisely as it sounds. Boil the pre-formed piece of plastic. It comes in a plastic form, but you boil it. So when you boil it, it becomes soft. Put it in the mouth, make movements that will mold that plastic in the mouth to cover the biting surface, and that will be a custom. It will be a better or more customized fit for the person wearing it. The last one is the custom-made mouth guard. Okay, this has to be done by a dentist. Okay, it's because it has to be fabricated in the dental laboratory. It's specifically designed for that one particular person. Okay, and, you cannot be sharing this mouth guard. Anyway, you should not be sharing. But the point is, it will not fit another person's oral cavity because it is suited to the impression of that particular person. Okay, and this will provide the best fit and protection for the athlete. It will be more expensive than the other two, but this will be most comfortable for the athlete. Now, what are the sports that require mouth guard use? Okay, you have the contact and collision sports, and then you have the limited contact sports and recreational activities. Now, all this requires one to wear a mouth guard. Well, unfortunately, I'm sure many of you who are in the administration part of this will agree with me that many of these events, we still do not have our athletes wearing it. Now, what is more important is like this can be mandated. Okay, this can be mandated by the organizations. For example, in the United States, the National Federation of State High School Associations have mandated mouth guards for football, field hockey, ice hockey, wrestling as mandatory. Okay, so the administrators can play a big role in this. Not only the administrators for that matter, even the coaches can make it a point that their wards wear it when they're active in the sports. Okay, so this probably is something that I would like to leave with you to consider, because I know many of you are in the administrative post also, and this is something that you will be able to do to help protect the athlete. Okay, now team sports protection. You know the helmet is one of the mandatory also. A sturdy helmet with a face guard gives an extra layer of protection in sports such as hockey, cricket, rugby, and other sports such as baseball require the special headgear. Okay, I am sure many of you are already aware of this. No matter the sports, what is important is there's a chance of hard physical contact with the jaw or face. So donning a helmet is also a very effective way of preventing these kind of dental emergencies. What about solo sports protection? Okay, even though there are minimum to no risk of being hit in a tooth with a bat, ball, or a person's arm when playing tennis, badminton, or running for that matter, one still faces the potential of falling and coming into contact with a hard ground. Okay, so one can also run into something such as a post or net, okay, because of the speed at which that the person is participating in the sports, leading to injury from sudden impact or poor visibility. Okay, so even in solo sports, it can be a requirement, okay, to keep yourself safe from these kind of injuries. Swimming protection, okay, again something that we might think that it may not make sense to have to protect the teeth. Okay, so why do I say this? Now, one face little risk of breaking a tooth while swimming. Okay, all of us know that, barring a bump to the mouth against a hard wall, but should protect mouth over long periods of the pool time. Okay, this is where the importance of protection, oral cavity protection takes place. Okay, if the pH of the swimming pool is too low, okay, this is too acidic, one is at a higher risk for what is known as the swimmer's mouth syndrome. Okay, there's a known syndrome, swimmer's mouth syndrome, and this condition can cause teeth to stain, dental pain, as well as increased calculus, or what you call the tartar formation in the around the teeth. Okay, so this is why it is important to even protect the teeth during the swimming activity, along with maintaining the pool and keeping the chlorine level at the recommended level. Protect the teeth further by keeping mouth closed when swimming. So again, this is an advice for swimmers to be aware that there is something called the swimmer's mouth, and you can prevent it by these strategies. Now, I'm coming to the end of my presentation. So to conclude, what are the symptoms that we have to be aware of to make sure that we get an appointment with the dentist? Okay, first one, tooth pain. Okay, all of you are aware of it. Jaw pain, sensitivity to heat or cold. Okay, when you take something hot, something cold, suddenly there is a sensitive feeling in the mouth because of the diet of the animal. Okay, this is another area of discussion. Okay, because I was told only talk about the emergency. Okay, prevention is another big area that, like I showed you in the first picture. Okay, it is a small matter because it is just affecting the teeth. It has not gone into a pain situation or something in any of those pictures that I showed you, but it will lead to all those emergencies, potentially lead to all those emergencies. Okay, so prevention of dental caries is another big area that you have to take into consideration. Okay, so just like sensitivity, you can also have pain triggered by sweet foods or beverages, persistent bad breath. Okay, that may be a sign that the gums are not healthy. Tender or swollen gums. Okay, it can arise from the gums or from a tooth, as we had seen earlier. Red gums, bleeding gums, tooth which is loose or even which is discolored. Okay, if a person had an impact on the tooth can necrose, devitalize, and it can change color. Okay, so these are all the symptoms that you can identify to make sure that you seek the dental care. So in conclusion, this is a humble piece of advice from the dental fraternity. Okay, if you or any of your ward play in a sports or participate in recreational activities, the use of a mouth guard should be considered. Okay, and this is, like I told you, this is a mouth guard. This prefabricated, okay, readily available, but probably it may not be as fitting as the customized. Mouth guard can reduce risk of mouth-related injuries, including on the tooth, lips, tongue, soft tissues. Okay, so it is always better to consider the prevention rather than the cure. And even recent studies have shown that the use of mouth guards can also minimize the severity of a concussion. Okay, because there is a lot of impact when you are in a active sports, and especially in a contact sports, and this also is effective in avoiding the concussion. And most important is visit your dentist regularly to avoid these emergencies. That is the most important thing. Try to avoid the coming to this stage of requirement. So a periodic visit to the dentist, depending on the severity of the oral condition. Okay, I'm not telling you have to go once in 6 months or once in a year or once in 2 years. Depending on the severity of the condition in your mouth, you have to have a discussion with your dentist as to how often you have to visit the dentist to make sure that you have in a proper preventive regime to avoid dental complications. I leave you with this. Okay, some of you might have be aware of this. Okay, but this is Swapna Burman. Okay, an Indian heptathlon. She won the Asian Games gold medal in 2018. Okay, now if you look at the picture on the left side of okay, this side, she's got something, a bandage there. Okay, so she was she is remembered for that also, in addition to having won the gold medal in the Asian Games in 2018. And why is that? Because that tape was used to tackle the severe toothache. Okay, so and all of you know heptathlon does not, it's just not a one event. It has got multiple events, multiple days of activity, and she was under excruciating pain and she won the gold medal. Okay, it's not saying that you don't handle your dental problems because you can still win a gold. Okay, that is not the message I'm giving you. Probably she could have got a better record if she was symptomless. Okay, and please don't wait until you go to that stage to get attention. Actually my encounter with sports dentistry actually was through my friend Dr. Sharif, who's here. When he called me, I think he was in Indonesia during one of the games, and he said one of our coaches has got a very bad tooth. It's paining, and I think it was a Sunday. And what should we do? Okay, so again, a message is please do not wait till that emergency comes in place for you to act. Okay, please act beforehand. Now I'm leaving you with a small session of a quiz, okay, which Dr. Chong will coordinate. So let me stop sharing and I hand it over back to Dr. Chong. Thank you.
Okay, now we will start I will launch a poll of a quiz for dental emergency in sport. So you just need to answer accordingly. It's a single best answer and each questions allocated about 30 seconds. Okay. Can you see the questions?
Let's see if we can get 148 responses. I think that's the number of participants here, right? Just see what, so it also improves on your dental knowledge.
I just roughly read out while the participant is answering the questions. Number one, an athlete who doesn't wear a mouth guard is 60 times more likely to suffer harms to teeth. The option is either true, false, or not sure. Second, your chance of receiving a dental injuries in non-contact sport is very slim, either true, false, or not sure. And then the third one, over 80% of all dental injuries involve the upper front teeth. Is it true, false, or not sure? Okay. The fourth, the mouth guard that is fabricated in the dental laboratory is called either stock mouth guard, boy and bead mouth guard, or custom mouth guard. Just now, Prof. Jacob already show is in his talk very clearly. If you pay attention to that, you answer these questions. Okay. And the last question is if the attached to the root surface has or have not been damaged by rough handling and a valve tool may have a good chance of recovering to full function. Either the periodontal ligament, cementum, or periodontal fiber. Okay. So we got 30 more seconds before we end our polling. Okay, I shall end the poll now. Okay, I will share the result. Probably Prof. Jacobs can help us to go through the results.
Okay, an athlete who doesn't wear mouth guard is 60 times more likely to suffer harm to teeth. Okay, I had shared it also in the presentation just now. Yes, small 60 times more likely is a true statement. Okay, so be aware of this when you are in your sports activity. Now, your chance of receiving dental injury in non-contact sports is very slim. Again, as I had mentioned earlier, okay, it is slim, but it can happen. Okay, it is still possible for it to happen because of the speed at which you are participating. It can still cause injuries, and I have also shared as to what is to be done to avoid these kind of injuries. Over 80% of the dental injuries involve the upper front tooth. Yes, because that is the most visible part of the oral cavity, because it's the front tooth. It is the most commonly affected teeth in the oral cavity if there is an injury in the dental side. The mouth guard that is fabricated in the dental laboratory, it is known as custom mouth guard. Okay, 75% of you have got it right. Okay, if it is fabricated in the laboratory, it has to be something that has to be custom made. We cannot get it from the over the counter from the shop, or even ask the patient to bite on that plastic block and get it fitted in the mouth. Okay, partially it may be a boil and bite is also possible, but it is not fabricated in the dental laboratory. So that will be the most precise mouth guard that you can have in your mouth, which will be fitting your oral cavity absolutely. Now, if I again shared this earlier, you should not touch the root surface of the tooth while the process of replanting the tooth because the periodontal ligament can get damaged. Okay, so that is this. To avoid that, we have to hold on the crown aspect of the tooth. Okay, that will be the whiter portion of the tooth. The root surface will be longer, and also it will be more yellowish. Okay, so hold on the crown surface of the tooth to avoid damage to the periodontal ligament, because then the vitality of the tooth is lost. So that's from our poll results. Hopefully it was of some benefit for your general knowledge on the oral dental aspects of dental sports emergency. I hand it over to Dr. Chong for the Q&A session.
All right. Thank you very much, Prof. Jacob. That was very interesting talk indeed. There are many types of dental injuries that can be sustained by the athletes, and they can be quite common also. Therefore, immediate evaluation and proper management would save the dental structure and function for the athletes. Okay, shall we look into the questions that are posted for Prof. Jacob? There are quite a number of questions. All right. Okay, Prof. Jacob. Okay, first question from Lee. If we save the dead tooth, how is the maintenance and how long will it be safe?
Okay, I suppose this is you mean the avulsed tooth.
Yeah.
Dr. Lee. Okay. Just like what I have mentioned just now, you have to follow the protocol, and the longer you wait, the poorer the prognosis. Okay. So the most effective one is if you can by yourself replant the tooth in its position immediately. Okay. But if you're not able to, then follow the protocol of placing the tooth in an isotonic solution, or even if the person is very cooperative, place it under the tongue okay, with the saliva there in the oral cavity in that region. It should preserve the tooth within the 30 minutes of you reaching a dentist and the dentist doing the procedure. Okay, and just now I also mentioned about the splinting is also very important. That the duration of the splinting, it is not just for a day or two. It's a minimum of 7 to 14 days, and if needed, the dentist may prolong the splinting to preserve the tooth in its original position for less damage to the particular tooth. You can still expect damages in the future, okay, but at least the tooth is back in its place. That is what is important.
All right, Prof. Gifford, second
Yeah.
question from
I will
To.
read it. Yeah.
Okay, if patient allergy with penicillin, what other medication can be used?
Okay, this most of you are physicians here, so I need not answer this. Okay, but penicillin, if not erythromycin, you can use tetracycline. Okay, because this again depending on the situation of the person, you can go to a antibiotic that is
The groups.
suitable for you.
All right, all right. Okay, third question from Prof. Ernest. Can you give some comments on the use of mouth guards in contact sports like rugby, boxing, martial arts?
Okay, now I'm not sure what sort of explanation I suppose Prof. Ernest had asked this question before I spoke about mouth guards. So it is mandatory. It is mandatory in all these sports that you are mentioning here. But beyond that, I also shared with you the benefits of having mouth guard, even in other sports that probably are not as contact related as rugby, boxing, or martial arts.
All right. Next question. In case the avulsed tooth has been implanted, is there any anticipated complication?
Yes, you can anticipate root resorption taking place after the tooth has been replanted. You can ankylosis of the tooth to the bone around it. Okay, so later when you are extracting or when the surgeon is extracting, you better inform that this tooth had a avulsed and it was replanted, because otherwise you'll get a big chunk of bone coming along with the tooth, or again you'll have fracture of the tooth and a lot of complications that take place. So you should be aware and inform the dentist even in the later stage if some treatment is being done. Yes.
All right, all right. Okay, next question, Chong. From you, what kind of agent can we use for the bleeding? Isn't adrenaline engulfs and ask the player to bite?
Okay, the simplest is first of all, we will place a cotton roll in the or gauze in the mouth and send the patient off. Okay, and hopefully the clot has taken place by the time we ask the patient to remove. But if the bleeding continues because of some exertion in the mouth and it has initiated a new bleeding, yes, adrenaline would be an added source of helping in the faster clotting, but it is sufficient for you to have a gauze well packed in that area to also sustain or to promote the clotting to take place. If it's available, yes, you can use it. It's not a contraindication. And also beyond that, you may even have to have some hemostatic agent to be placed inside the socket and then place the gauze. It's at how much of bleeding is taking place and how long the bleeding is taking place. That is what you have to assess and accordingly manage.
All right. Okay, next question from Prof. Ernest. Having found a loose tooth on the rugby field, but could not find a dental practitioner to deal with the emergency, is there any chance to reimplant the tooth?
Okay, again, it was covered in the presentation. It can be done, okay? It can be done either by yourself, if you know the protocol well and you follow the protocol, or you can transfer the patient. But transferring the patient within 30 minutes, you should have reached the dentist. And the longer you delay it, the less the prognosis. Okay? So probably this is an avenue for me to suggest that you have a dentist also in your team during the sports activity. What do you say, Prof. Zul?
Yeah,
As part of the team,
yeah.
at least somebody who has the knowledge of doing this within the team will be helpful. You need not be a dentist.
Yeah, definitely. They need to be responsible on what to do. Right. Next question. I think almost you already answered question number 7. And Adam asked, what type of milk is best to preserve the avulsed tooth? Can you give an example of the pasteurized milk for preserving the avulsion tooth?
Okay, it is milk that lasts. It can be preserved longer. Okay, that I mean, in basic terms, I think that's what is most important. It has got a lifelong. It has got a longer lifelong life period. You can use those kind of milk to preserve it. Okay, you can also use. I was surprised that you can even use contact lens fluid as one of your
the solution.
solutions. Yes.
Any brand that you can use?
No, I'm not promoting. I'm not promoting.
All right,
sorry, I'm not aware of it. I'm sorry. That's
okay,
my
sure.
actual answer.
Right. Next questions. Okay, let's say the crown fracture or tooth avulsion is managed or corrected by the dental surgeon step after a semi-final karate event. Would the athlete be allowed to play for the final event the next day?
Okay, that will be a decision that you will have to make. But from the dental point of view, avulsed tooth, yes, it will be not advisable, because even though you do splinting, it can pop out. Okay, because the tooth, it has not formed any bond with the bone yet. Okay, we are holding it, we are splinting it in position so that it allows the tooth surface to bond with the bone around it. So if you do not allow that to happen, it can dislodge and you're back to square one. Okay.
Right.
So from a dental point of view, it is critical that you do not exert any pressure on that area. Okay, but it's up to how you look at it, how the athlete and the coach decides finally.
All right. So it's actually individualized, right? Depending on the situation. Yeah.
Situation.
Okay. The last question from Prof. Ernest: should athletes undergo pre-participation dental examination? There have been occasions where performance was affected due to the dental discomfort and pain. Yeah, as you discussed yourself.
I think you answered it yourself.
Yeah.
And we would love to be part of the sports team. Okay. And I'm sure, like from the study that we have done itself, we have seen that we are not proud of what we have seen. And it is the fault of the dentist also, because we have not captured this at an earlier stage. But it would be good if there is a collaboration with the sports agencies and the dental fraternities. We have many dental schools now in Malaysia. We also have a very good what you call oral health program within the Ministry of Health. So it's workable.
All right. Wonderful, Prof. Jacob. Thank you very much. Okay, for your interesting session.
Sorry,
okay.
2 more questions. Two last questions.
Two last questions. Sorry. Okay. Question from Izham. How do splinting on teeth? If a player has tooth avulsion, will he be able to complete the playing time before seeking emergency treatment?
Technically, probably. I mean, it depends. If it's just going to be another 15 minutes, you can wait. But then you also may be encountering bleeding happening at that time. Okay, so again, a decision has to be made. How according to that individual's situation. Okay, but ideally, no, you have to place back the tooth in position and stop the activity. How does splinting take place? Now we use wires and tie it up to the adjacent teeth. Okay, that's the most effective way. We can also bond it. We have composite materials that can bond to the adjacent teeth. What is important is that tooth is immobilized during that healing process. So which best way you can immobilize the tooth, that's what we do.
Yeah, all right. That's the new technology, yeah? All right, the last question from Isaac. Does sports drink increase the risk of getting dental caries?
Yes, like I told you just now, this is another big area that we have to look into, okay, because it is today we are looking at only what you call
Injuries.
emergencies and injuries. I did not touch on this.
Touch on prevention.
Yes, sports drinks. Even just imagine if you are running with your mouth open, you have your oral cavity in a dry position. That itself can cause more damage to the teeth in the long run. So there are a lot of things that we can discuss. And to answer that, yes, sport drinks have got tendency of creating dental caries also.
Is it because of the carbohydrate inside it?
Yes, yeah. It's the composition of the drink.
Wonderful project. Interesting. All right. Shall we go to our next speaker? Okay. We have Prof. Rashidi Ahmad next. He is a professor in emergency medicine and a senior consultant emergency physician, currently serving the Faculty of Medicine, University of Malaya and University Malaya Medical Center. He attained his medical degree at University of Science Malaysia, Kelantan in 1995 and pursued his postgraduate study at the same university in 1998. He completed the Master of Emergency Medicine in 2002, and his subspecialty emergency training areas are cardiovascular emergencies, pain management, and disaster medicine. He has 14 years of experience in teaching and training. He involved in many competency training, okay, to name a few: basic life supports, advanced cardiac life supports, pediatric life support, neonatal resuscitation, so on. Okay, there's plenty of competency training that he actually involved in, and he is also a renowned academician in his field, as he has published many articles in journals, proceeding, and monograph. He has been invited to speak in many conferences, seminars, symposium, and workshop. Okay, his talk today entitled "Medical Emergency in Sports." Okay, I would like to welcome Prof. Rashidi. The floor is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi ta'ala wabarakatuh, and very good morning. First of all, thank you very much, Prof. Dr. Zakarin, for your kind introductions. May I get my picture, please? I cannot start the video because the host has stopped it. Hello?
Chong? Hello, Chong?
Okay.
Prof, can you try again?
Okay. I can't.
Okay, not sure.
I can't, Chong. Sorry. But never mind, Chong. If you cannot, I just share the screen with the audiences.
Okay, yeah.
Okay. Can you see the slide?
Yeah.
Okay,
very clear.
Okay. Thank you very much. Okay, so I'm going to start our discussion with a few questions. So this is what I want the audience or participants to assist me. All right. Now I'm going to give you questions. Now can we go to the click to the chat? Can we click the chat? Okay, where is the chat? Oops. Oops. Oh my, okay. Chong, how to go to the chat? Huh?
You just need to click on the chat button at the lower panel. So, and you will see
Q&A,
the three dots.
The three dots. Okay.
The chat. There's a chat box.
All right. Okay. Thank you very much. Thank you very much. Okay. Now, okay. I will give you the questions, and then if you agree with these questions.
So your question, due to time constraint, you encourage you to.
Okay. All right. Okay. Now the question is, who had experience managing sport emergencies? Now, if you have experience in managing sport emergencies, please type Y. Okay? Can we do it now? Okay, please type now. Oh, good, good. Okay, go on, go on. Okay, good, good. Okay, some more, that's all. Okay, okay, okay. We have another few. Good. All right. Okay. Okay, who have no experience in managing sport emergencies, then you type Y. No, sorry, N. Type N. Okay. Okay, Y. All right. Okay, okay, all right, okay. So some of you had experiences in managing sport emergencies, some of you none. Okay, so okay, fine. Okay, okay, okay. All right, all right. Okay. Thank you very much for your participation in the discussions. All right. Now, by the end of my presentations, you're going to learn two important things. Number one, understanding the sport emergencies, particularly emergency physician perspective. Okay. And number two, what is the strategies and also techniques in order for us to manage the sport emergencies. In other words, we're going to discuss about the administrations. The host has asked you to start your video. Okay. All right. Is it okay now, Chong?
Yes, we can see your video clearly. Yeah.
Okay, right. Can you see my face?
Yeah, face.
Okay,
Handsome
right.
face. Yeah.
All right. Thank you. Thank you. Okay, so number one, you're going to learn about sport emergencies and what is the strategies and the technique in order for you to manage the sport emergencies in general. Number two, we're going to focus to out of hospital cardiac arrest, particularly at the sport medicine point of view. And of course, since that the American Heart Association guideline 2020 already launched, so we're going to touch a bit about the OSCA according to this EH 2020, and then how we're going to modify it according to the our fraternities or sport medicines. All right. Now, in order for me to achieve the learning outcome, so this is the outline of my presentation. First, we're going to discuss what is sport emergencies, particularly at the emergency physician perspective. This is a very, very important because I noted that we have many representatives from other departments. So therefore, I'm also like to highlight the emergency physician perspective rather than internal medicine perspective. Of course, I do understand that our topic is about medical emergencies, but I think it is the opportunity for me as the representative of emergency medicine or emergency physician to inform everybody regarding our perspective. And I hope by understanding this perspective or the definitions, the work processes, so that we can work together between the sport medicines, okay, fraternity, and also emergency medicine fraternity. Now, I'm going to highlight the important mnemonics in the sport emergency management, which is pre-disasters paradigm, then followed by discuss about the chain of survival according to the EH 2020. I'm going to highlight the OSA and also ISA, and then I will like to suggest the modified chain of survival for sport medicine, if you agree with my proposals. And next, we're going to a bit detail about the management of sudden cardiac arrest. I think this is the most important things when we discuss about the medical emergencies, because people really focus when especially if your athlete collapse at the scene. Next, I'm also going to highlight the CPR, cardiopulmonary resuscitation, versus the CCR, or the crinocerebral resuscitation, so that we can understand better that how the physician, either sport physician or emergency physician, can enhance the resuscitation management at the fields. Okay, so these are the few things that I'm going to discuss. I hope that within this 45 minutes, we are able to discuss all. Now, first, let's understand our perspective or emergency physician perspective regarding the sports emergencies or sport medicine. Number one, for us, we divide them into extreme versus non-extreme sports. Definitely, what we worried so much is this extreme sports. Okay, so that's we know that these injuries may occur. Even the medical also can, the medical problem also can occur. Now, if you read the articles, okay, beside that, we understand about the channelopathy that is associated with the cardiac arrest. There is also a term that nowadays people start talking about, which is a commercial cordis, for example, whereby when someone hit the chest, then suddenly the victim develops the life-threatening arrhythmias, either VF and also VG. Okay, so it may happen. So we have extremes and also we have the non-extreme sports. That's definitely the worry. The worry will be the extreme sports. That is the worry, and then the management, the strategies is different. I've been involved in Formula One, Japan GTs, motorsports. I've been involved in the Langkawi Tour. So the management of this extreme actually is very challenging. For example, that we have to understand that we spot that maybe associated with injuries, for example. Okay, so that's definitely in the traumatic point of view. All right. Next, we also noted that the sports can be individuals, can be duels, or can be team sports. Okay. For example, like we have the boxing, two persons, and then we have this like football. There are so many people that involved. We have a marathon, for example. There are so many people that involved. And then when we're talking about medical coverage, we are talking about the player, and also we are talking about spectator. Of course, example for spectators, the most important one is the public and also VIPs. Okay, I involved many of time. I've involved in covering this player and also the VIP. And then trust me, the covering the VIP is more difficult. For example, like I've been opportunity to cover for Tun Dr. Mahathir. I need to understand certain things about the heart, his heart condition, for example, and then we need to understand the flow, for example, because we need to make sure that if something happens, we are ready for it. Now, discussing about players, okay, in relation to sport emergencies, the players can be small kids, child, can be youth, adults, can be Paralympics athletes or disabled athletes, and even veterans. Now the worry now is that many veterans also involved in this sport. And then, as you know, that in Malaysia, based on the statistic, it shows that 60% of Malaysians had pre-vessel disease, but they are walking around. Okay, so just wait for the correct time when suddenly the heart rate die up, and then patient will develop chest pain, and then they may collapse. All right. Now, pertaining to sport emergencies, okay, we have trauma. Okay, we have medical problems. Okay, and also we have CBRNE, for example. Okay, CBRNE stand for can be chemical, biological, radiation, nuclear, and explosion. I think the famous one, the mass casualties in sport is the explosion, bombing, and then I believe that you remember about this marathon bombing in US, Boston. Okay, all right. So sport emergencies can be trauma, can be non-trauma. Okay, it can be single person that involved. It can be multiple. It can be mass casualties. Now, what do you mean by multiple? What do you mean by mass casualties? Multiples, it means that the number of the victims. Simple meaning is that when your demand and resources is equal, or you have more resources, meaning that your resources is more than demand. But the moment that you have the condition whereby your demand is more than your resources, we call it as the mass casualties. Okay, so sport emergencies, worst case scenarios, CBRNE, worst scenarios is the mass casualties. It can be medical and also can be trauma. Okay, now last time we discussed that in cases of in sport there are only mainly trauma. No, it's not true that I discussed with just now, we are so-called that the undetected channelopathy, it just that it needs some event to perpetuate, and then patient having this VF and VT. So in general, as an emergency physician, we estimate the cases according to this ratio. There is no evidence about this ratio, 30, 10, 1. There is no evidence about these ratios, but it's just for us to be prepared. Worst case scenarios, we have to prepare, meaning that in one event, 30% will be the minus injuries, 10% will be the moderate to severe injuries, and 1% may be life-threatening, or even it can cause even death. Okay, so this is the estimated cases, so that we're able to prepare for ourselves. Okay, now emergency medicine, we serve the fields. Okay, we provide our service to the fields and roads, and also at the emergency department. All right. Now, I just want to highlight these four most deadly sports in the world. Now, of course, base jumping, for example, like parachute, bungee jumping, is considered as extreme sports. Okay, so the death is about 1 in 2,000, for example. Swimming, okay, swimming, cycling, running is not that extreme, but you can note that the death also is quite worrying. For example, like swimming, 1 in 56,000, 1 in cycling in 1 in 90,000, running in 1 in 97,000. Why? Because not many people involved in the extreme sports. Okay, but it's non-extreme sport, swimming. Many people do swimming. We have so many swimming pools in Malaysia, for example. We have many people love cycling. Many people also love running. Then you can see that the numbers of the incidents, particularly the mortality is quite significant. Therefore, as the sport physician, as emergency physicians, we have to worry about this. We need to be prepared in dealing with these sport emergencies. Either it can be trauma, or it can be the medical problems. All right. So this one, I'd like to highlight that CBRNE related sport emergencies. Okay. So of course that we think that our country is a bit safe, but if you remember, we have few riot events at the stadium. For example, at Kota Baru, we heard about that story. At Kota Baru, we have about the riot at the stadium, Kuantan Stadium, for example. Okay, so maybe it is a minor one, but maybe in the futures, we do not know. Okay, particularly if we involve in the international sport, for example. Okay, so be ready. Okay, don't take it very lightly, because it may happen. Now, what is our roles? Okay, my roles as a emergency physician, others' role as a sport physician, as a healthcare providers, whatever. So definitely that according to the emergency management, our role basically there are few. Okay, there is a standard. Number one, we want to save life. Okay, that's our number one. Number two, we want to save limb. We want to save organs. Right. Number three, we want to relieve the suffering. And number four, we want to prevent the further deteriorations. And number five, do no harm. Okay, do no harm. Okay? And number six is do some good. So these are the principles about the emergency management. And then therefore, our role is that looking into this perspective. Okay, because we want to save life. Next, we want to save the limbs. Okay, we want to save their eyes. We want to save their organs, their heart. We want to relieve their sufferings. Sometimes they are very in severe pain, for example, chest pain. The veteran during the exercise or during the marathon, whatever, develop the chest pain, got MI, for example, severe chest pain. So you need to know how to relieve the pain or reduce the pain, and then prevent further deteriorations. Okay, once again, the factors of time is very important. Time is of the essence. Okay, and next is that we want to do that something is appropriate, okay, acceptable during that time. Maybe not achieve the standard, but appropriate standard. I think that's the keyword for the field management, not the standard management, but the most appropriate the management at the fields. All right. Now, for emergency physicians, the focus is the critical time interventions because because we believe that time is gold, time is very important. We believe that it's time loss, electrical loss, time loss, microdome loss, time loss, microdome loss, electrical loss, in stroke, time loss, brain loss. Okay, then in trauma, we discuss a lot about the platinum time, platinum minutes. We discuss a lot of the golden hour, okay, to show that the critical time is intervention is very, very important. So therefore, the management of sport emergencies need also to considering all these so-called life-threatening event that require life-threatening intervention at the field. We don't have time. I'll give you example, a patient with the commotiocortis, patient collapse, definitely they require the effective or high quality chest compressions. They require the rapid defibrillation. Okay, time is very, very important. Now, for emergency physicians, our enemy is a time. Is very, very important. Okay, this why I'm going to show. I'm going to inform you. Many of time that what we do is that we bring the emergency to the field. We not bring the patients to the emergency. We bring the emergency to the patients. Okay, so the concept become the initial concept because the histories of medicine is that this history of medicine is whereby the doctors go to the patient house and manage the patient house. Since that there are so many patients, the number of doctors also minimum, so therefore the patient has to come to the emergency, to the hospital. But in the sport emergencies, the emergencies, we need to bring the emergencies to the field. Okay, that is the key point. Now, whatever we do in the emergency department, we need to bring it to the field to manage it because that is a very, very critical to relate. So the initial management, the aggressive initial management is not at the ED. The initial aggressive management or the critical intervention must be instituted at the fields. Okay, or you can say that is stay and play rather than scoop and run. Okay, this concept is a stay and play. You should not practice the scoop and run, or you practice the Anglo-American technique. We need to adapt the Franco-German technique, whereby stay and play. All right. Okay. Number one, the most important is the critical time interventions, and number two, we must be able to organize the chaos. Okay. So these are two very important things that we need to discuss in relation to the sport emergencies. Number one, critical time interventions, and number two, organize the chaos. Of course, next question that you will ask me, how are we going to do it? Okay, all right. No, so I'm going to give you the tips for us have an idea that how to manage these worst case scenarios, such as like mass casualties or whatever. All right. Now, the mnemonic that I want you to write, okay, write it down, or you want to remember, okay, better for you to write down because this is a very popular mnemonic used by, I think, almost all emergency physicians in Malaysia, particularly. We are using this mnemonic for the emergency management or the emergency administrations, particularly in the if you read or you understand about the emergency life cycles, there are two important phases, okay, that is very crucial. Number one is the preparedness, and number two is the response. In other words, that the emergency preparedness and also the emergency response is very important. So we need to bring this understanding about this emergency preparedness and also emergency response in the sport events, particularly that involve so many people. So either this player itself or the marathon guy, and also the spectators, and then the VIPs. So we need to bring this concept. So the mnemonic is pre-disasters. Okay. So pre means is related to the preparedness. What we should do during the preparedness. Disaster is the response. How should we respond? Okay, this is to give you the general idea, so that when you ask manage the event. So you can use this mnemonic in order for you to complete your tentative or your plan, for example. Okay, what is a pre? Pre is number one is the a plan and also the practice. Okay, you must have plan, you must have practice. So you need to prepare for the plan, then after that you need to practice it. I mean resilience meaning that you need to have a team that can stand the stress during the event, for example. Okay, and then E stand for the education and also the exercise. Okay, so basically, you need to have a good team, come up with a good plan, and then after you have the plan, you need to exercise it, and then you need to improve it. So that's what I mean by the emergency preparedness, and then we're going to discuss more. Then after that, if it's happened, so you can use this mnemonic disasters. Yes, the D means detection, early recognition. I is the incident command. You need to have the governance, a proper governance, understandable governance, because you are not working alone. Okay. S stand for the safety and also securities. Need to think about the safety and also the security. A is the technique of assessment. S is a search capacities and capability management. T is triage, tag, and treatment. E is about evacuation, and last R is recovery. Okay, there are a lot of things to discuss about this, but I just want to highlight to create awareness so that you understand that certain things that you need to cover in order for us to prepare the sport emergencies. All right. Okay. All right. I informed you just now about this pre. Now I'll give you an example. Now if you have the event that coming in front of you, okay, so at least you need to perform this so-called very standard emergency preparedness, which is the high rank. High rank means that try to understand the hazards, and then you perform the risk the risk assessment, and then you come up with the risk control. You should do this. If someone invite you to cover, you need to do this. Not only you, it's not all the event is similar. Okay, you need to start dividing the categorize the case. Is it extremes? Is non-extremes? What is the risk? Who are involved? Veterans, whatever. You need to understand. Is the VIPs, whatever. Okay, so that's why sometimes that it's possible. We should not cover for all the publics that involved. Okay, we just focus. Okay, maybe for public, what we need is the first aiders. Okay, for player, so we need the more emergency services. We need police sometimes. We need fire service sometimes. Medical, and then also we need the VIPs for another groups. Okay, so we need to understand and then look for the hazards. Okay, so be prepared with all this. Okay, and then do the risk assessment and also the risk control. I give example. There is a very famous risk matrix. Okay, that looking into the severity of likelihood, because risk means hazards time exposures. Okay, exposures is the vulnerability, which is severity and also times likelihood. Okay, so every time that we try to do this this diagram, this metric, so that we understand what we are dealing with. Okay, we need to learn from the previous one. What has happened before this? For example, in Malaysia, we have this riot at the spot. We have to think about it. The severities. What happened? We have those mentioned with eye injuries, for example, whatever. Okay, we have this player that may have been cardiac arrest, for example. So we need to understand the likelihood, what is the frequency, for example, so that we can do the map, and then we can come up with the solutions. Okay, and also the further preparation. For example, in some conditions, maybe you need to refuse. Okay, and then some conditions, maybe you need to substitute the place, for example. Okay, so engineering control and risk control MP. So the hierarchy is a topic by itself. Is good. It's good for you to learn about this hierarchy, so that before you accepting any coverage for any events, you must first is do your homework first to understand the hazard, understand the risk assessment, and come up with these proper methods of control. If you can't, just eliminate. So I have to do this. Even I have a fight with police in Bobo last time when I do the coverage with Tun Mahathir. So I said, no, Dr. Mahathir cannot go through this ladder. This ladder is meant for young people, not meant for the elderly patient, for elderly people, especially with these cardiac problems. Okay, so you just set it out based on your risk assessment, okay, and document it. It's very, very important before you start. All right, then after you have hierarchy, then you can come up with your plans. Definitely you need to train your staff, for example, exercise the plans, okay, and then they try to revise and amend if any is possible. All right, okay, sometimes you maybe want to do the tabletop exercise, so particularly when you're dealing with this mantra mnemonic, okay, so you need to understand where to go in, where to go out, the access, for example. So when I involved in the F1, for example, so we have this pool of doctors from the armies, some of them from the Ministry of Health, for universities. We have to attend 3 times exercising. Okay, even we have a conference discussing about what is the possibilities. Okay, so the medical page is something that is very, very serious. It's not it's not like you just touch and go. You know, you need to really, because if something happens, it will give a bad name for you and also for your institution. Now, this for me, these life-saving rules is very, very effective. Okay, when you start plan your team and also your the events or the coverage. Okay, I call it is 5S. So every time that you want to have event, after you do the hierarchy, the assessment, think about the 5S. What system that you want to adopt? The structures, okay, of your management, the space, the staff, for example. So you need to think all this, okay. So before you start, I give you example that we need to have this idea. Okay, it's a multi-sectoral rescue chain. You need to have this because you cannot work alone. You depend on hospitals. You need to understand the hospital organizations, the pre-hospital organizations. Okay, pre-hospital organization include the field management and also the transport management. You need to. Okay, you need to very, very clear. That's why sometimes that you have to call the hospitals, okay, call the emergency department, that whether they're willing to accept the cases or not. Okay, for example, like when we did the F1, for example, so we have helicopters, and then the hospital that willing to accept is UKM, for example. So we need to pre-plan first, get the permissions. They must get involved. Okay, there must be a proper seamless continuum of care. Okay. It's just not like patchy there, patchy there, patchy there. No, this is a professional thing. Medical coverage is something is professionals, and we always ready. Okay, so we need to understand about the system that we're going to adapt. Okay, of course, I'm not to force you whether you want to apply the Anglo-American or Franco-German, but I expect that for sport emergencies, we adapt the Franco-German technique rather than the Anglo-American techniques. Okay, that's what I believe. And then, so therefore, we need to understand the impact zone, possible the impact zones. We need to know where we put our medical base stations. Okay, so we need to know the access, okay, the egress and regress of our transport and route management, the staff that involved. There are so many that involved here, whereby you need to apply your 5S when you manage the sport emergencies. Okay, so I just want to highlight that usually we have like impact zone. So like say this, we are preparing for possibility of stadium riot, for example. So we know where is the impact zone. We know where is the safe place for where is the medical base stations, where you park your ambulance, where you load your patients, and then how it will go. How is go the traffics to hospital, for example. So all must be well understood, okay, well managed, and then it's need to involve this multiple organization. You cannot do it alone, right? Okay, I just give you examples that you need to see. First, you need to understand the system, and number 2, you need to see the structures. Okay, these are the structures that how it looks like. So if you not understand about this, is fine. I just want to to highlight, to create some awareness. If you need the detail about the discussions, then maybe next time that you can call me, then we can go to go in detail, okay, in the futures. All right. Okay. Once again, you cannot do alone. It's a team effort. It's a team management. You are is who are you is not important. The most important is that what is your task. It's not that, oh, you professionally or this. No, no, no. Even if I was given the task as become the triage, for example, that is my task. Okay, it's not that because I'm professor I must do this. No. Okay, during the sport emergencies, everybody will be given a task, and please perform your task, not perform other people task, whether you like it or not. Okay, it should be controls. Okay, four important things that the team management is command, control, coordination, and the communications. All right, leadership is very important. Need to very clear the command system. Of course, that I propose is the incident command system. If you need this topic, I can discuss later. But it's very, very important because many of the time that when we are the field, we are lose the control. In fact, the suggestions, communication is using the trunking system. But most of the time, we are not using the trunking system. What we use is the radio frequency. So how are you going to control if you're using the radio frequency? So trunking system is one way which is well work in the incident command system. Okay, so leadership is very, very important during this sport emergency. All right, and of course, who are you without the equipment? Please, when you come to the field, please come with the proper equipment. All right. So we already discussed about the preparedness. Next is the response. If something happens, we need to prepare detection. How are we going to detect? This is very, very important. Okay, because we of course the leader will be stay in the so-called the command we call it these command centers. Okay, so we have these command centers. We also need to the command post. Okay, why we need the command post? Because it's detections. We need to detect. For example, when I involved in F1, every corner we have the person that in charge. We call it as a command post. When we see when the bike or the car skidded, we just call the command center. Hello, Zulu leaders from Charlie's car skidded at this area. So then we start zooming, and everybody will zoom at that area. Understand? So why? Because we need detect, and then they have to make the decision. The incident command will make decision. Who should go there? The safety car, for example, or the Bravo. Bravo means is an extrication, ambulance. They need the anesthesiologist, for example. Okay, so need to be safety and securities. Okay, need to be applied. Assess hazards, search capacities, triage and treatment, evacuation recovery. So all these need to be applied at the fields, either is individual, multiple, or even the less specialized. Okay, good. All right. Okay. So once again, I'm already covering the first topic. Now I'll go to this second learning outcome, which is the medical emergencies. Okay. Now, sorry. Okay. Since that I have another 15 minutes, so I just skip these questions. All right. Now, how about this death among athletes? Is it common? Is it uncommon? Is it rare? Do you like to answer this? Okay. Let's go to the chat. I have the difficulty to go to the chat. Okay, I got it now. Okay, now what do you think about this death among athletes? Now, whether it's common, uncommon, or rare? Can you write your answers? What do you think about this? Rare, okay, uncommon, dog, okay, rare, okay, rare, okay, all right, okay. So everybody have different opinion, but definitely is either is uncommon or rare. Or some people say is not uncommon. Maybe uncommon, not uncommon, and also rare. Okay, of course, it's based on your experience. Okay, I'm not saying that you are wrong. Maybe that if you involve veteran, for example, maybe you've seen more common. If you involve in the extreme sport, maybe for you is common. All right. So if you involve in non-extreme individual sports, maybe it's considered as rare. Okay. Now the point is, okay, though it's too rare, do we have to worry about? Okay, do we have to worry? Okay. Now this is a list of answers. So since that the sudden cardiac arrest is rare, but do you think that you have to worry? Can you answer? Do you have to worry? All life is important. Agree. Okay. Okay. Agreed. And anyone ideas? Anyone disagree? Okay. Okay. Superb important. Okay. Very good. Thank you very much. Thank you very much for your participation. All right. Yes. If you ask me, we need to be serious about it. Okay. Why? Because any sport event is considered as sensational. Okay. As we can say, some of them is considered as the celebrity sport. Kan? Okay. For example, like Kevin Beckham. Sorry, I'm not very good in to tell the names of this sport because I don't like sports. Okay, okay. But it's considered as a sensational. Okay, everybody learn about it, especially football, for example. Okay, of course, Malaysia with soccer, some people is football, whatever. But everybody watching, is a live streams. If any event, you have to Zoom, so. And then you have to come to attend. People see you. Okay, what you do, that happened to the I'm not remember the MotoGP last time. Who's the name to Rossi something that they do Rossi they did accidents, and then my juniors, okay. So mind you, after a week of trainings, so they have that event okay, in Malaysia a few years back. Okay, and then they're zooming, so they scoop the patient, scoop the drivers. What happened? Suddenly they tumble, Paulo Rossi itu jatuh, so everybody zoom. How much they have to pay? 30,000 because of that event. So it's something that sensational, and then they record it, and then they can be. And then they can record it and then repeat again, and then what they see your face there. Okay, who are you? Okay, let's say that Prozulkanain. Okay, Prozulkanain is running to the patient and then CPR, and then during time we happening, and then we don't know sometimes what we perform, and then everybody see it, everybody comment about it. Okay, so take my words. Okay, though it's very very rare, you need to well prepared. If something happens, you must be appropriate. No mistakes. Okay, mistakes are not allowed during the time, because why? You will be assessed. Okay, you will be your problem will be highly addressed. Okay, so take my words. All right, when you perform the medical coverage. Now the incidents. Okay, we just now I agree with you that it's rare. So you can see that the team-based sport incident is about 1 in 65,000, up to 200,000 deaths per year. Italy, for example, 2.3 in 100,000 deaths per year. Interestingly, 2.1 from this 100,000 deaths per year is a cardiac in origin. Very, very important points. Cardiac in origin. Really, that you get this heat-related illness that cause death. Really, that you have this either you can say heat stroke or exertional heat stroke. It's not that common that cause the sudden death, but most of them, right, is a cardiac in origin. Okay, so you need to tune your mind that majority of them is a cardiac in origin. Okay, even trauma also can be cardiac in origin. All right. Okay, and then 50% of the sudden cardiac attack is sudden and also unexpected. Okay, definitely. Okay, unexpected. Okay, this is the list of sudden death among the athletes. You've noted here. Okay, I think most of them, okay, majority of the cases are the cardiac. HOCM, for example, commercial codies, coronary artery anomalies, diabetic hypertrophy, myocarditis, blah 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 blah. Then down below you see the asthma, okay, is that contribute about 2.1%, heat stroke only 1.6%, drug abuse 1%, okay, long QT syndrome 0.8%, for example, but HOCM 26.1%, commercial codies. Okay, so be alert. Any case that related with the injuries to the chest, okay, any games that related, for example, MMA, for example, okay, because this trauma is trauma induced, okay, knock to the chest will lead to the arrhythmias, okay, and it's contribute about 90.9%. HOCM, for example, is actually easy to identify. I was informed that you're going to have the cardiac cardiac sports, okay, discussions with the cardiologist. So I hope that he will highlight all these cardiac issues in sudden death, right? So this is the ratios about what we discussed just now. Okay. Right now, the issue is how, okay, since time is limited. Now, if you read the Chain of Survival 2020, you noted that there are in-hospital cardiac arrest and out-of-hospital cardiac arrest. Out-of-hospital cardiac arrest start with activation of emergency response. RSCA is start with early recognitions. Then if you noted that the in OSCA we have advanced resuscitation. In ISCA we don't have the advanced resuscitation. Now, I would like to propose this for the spot the chain of survival for sports events should be start with the preventions, okay, not start with the EMS response, okay, start with the prevention, followed by early recognition and activations, okay, then followed by high quality CPR, rapid defibrillations, and advanced resuscitations at the field, and followed by en route treatment and also post-resus care. So it's a bit different from the OSCA according to the AHA guidelines, okay, whereby it start with the activate emergency response, you identify, then you activate, followed by high quality CPR, rapid defibrillation, and then send patient to the hospitals, and followed by the post-resus care and also recovery, okay. So this modification I made by myself, I'm not sure whether you would agree or not, but I think that you need to look into it, because what I informed you earlier on is that we're going to bring the emergencies to the fields, okay. Okay, screening and about the screenings, okay, it will be discussed by the cardiologist about cardiovascular screening, desensitization, acclimatization, prophylactic rehydrations, because we have experience in Japan GTs. There are few of that Japanese, you know, and they end up with the heat exhaustion near to the heat stroke, you know? So therefore, so we start with the prophet rehydration for this. Now, and then I believe that one of the reasons, because they are not doing the desensitization. It's not like these European drivers. I used to see them, they are running during the hot sun, you know, so that if they can desensitize toward the high temperatures. Okay, medical response to the collapse victims. So this what I advocate, DRS ABCD. You may disagree with me. You may want DRS CAB. Doesn't matter. Okay. So what I want to say, doesn't matter whether you want to CAB, whether you want to ABC. Don't fight because of this mnemonic. The most important is that understand the mnemonic. Okay. Actually, I have a questions, but I don't think that we have a time to discuss about this thing. But this is very, very, very important for you to refresh those of you that who do not have basic life support, for example. Please learn about it. Okay, and then my advice is that please learn BLS, not CPR. Okay, please, CPR is just high quality CPR. Okay, you need to learn about this basic life support. You need to understand about the chain of survival. Now, for doctors, you need to learn the OSCA, RSCA, and also the advanced cardiac life support. Modified versions but it's very, very suitable with you because you are bring the emergencies to the field. So you need to be a bit all-rounders. Okay, you can mask and mask you. Okay, you must know how to use back valve mask, and also you must know how to use the LMA, for example, at least. Okay, using the LMA at the fields. Okay, all right, good. Okay, okay, I don't think I have this time, but okay. Now the great advantage about futures, okay, whereby you're going to see the physician at the fields. The doctors will be around. Okay, emergency physician, spot physician. So you have better team in the futures. Okay, we should work hand by hand to look about these issues. Issues about ventilations, we can provide LMA, UTT. Issues about using the real-time audiovisual feedback at the fields, using the drugs, for example. Why I come up with this issue of drugs, and also the issue of the intraosseous, because it's relevant, it's important. Okay, sometimes at the field it's not easy for you to get the veins, and then you should go with this IO technique. Because why? You need the drugs, okay, either the adrenaline to support the circulations, or you need the anti-arrhythmias for the refractory life-threatening arrhythmias or refractory VF and also VT. Okay, now I just want to highlight about the CCR and also CPR. These the studies in 2010 that highlight that this cardiocerebral resuscitation has a better outcome compared to the CPR at the fields. Okay, and also is supported by the concept of hands-only CPR. Okay, it's very, very important. Hands-only CPR. Okay, you apply early detections, hands-only CPR, and then CCR. Okay, doctors come in and start with your drugs. Okay, it take especially the very, very critical time is within the 1 minute, because the brain tissues will 100% will be damaged, okay, after about 10 minutes. In fact, it has been shown that every 1 minute delays 7 to 50% mortality outcome. Okay, so this is what we should do in the future. All right. Okay. It also shows that better outcome if patient has the shock ablator. Okay, based on these studies, you can go through this about these studies. All right. Okay. The summary and conclusions, ladies and gentlemen, I just want to highlight that sport emergencies are real. Okay. As emergency physicians, we look at divers. We look at as whole. Okay, we categorize them, and then we need to prepare. Okay, the most quoted impressed quotation by the Benjamin Franklin: if you fail to prepare, you prepare to fail. Okay, and you must do the right thing right. Some people say that you must do something that is effective, efficient, and rapid. Okay, please remember about these pre-disasters. You can Google and check what you mean by pre-disasters. You can apply it in the any sport events, and then please refresh your BLS according to recent 2020. And it's a time for you to practice these cardiocerebral resuscitations happening at the field in order for us to at least to improve the ROC. Okay, of course that at the end of the day we judge or the neurological outcome is the best for us to assess, but at least ROAC, and next is the neurological outcome. Okay, so get the ROAC first, and then we can talk about the neurological outcome. So I still believe that cardiocerebral resuscitation is a way forward in the futures in the management of the sudden cardiac arrest. Okay, now Dennis when they said that expect the best, plan for the worst, and prepare to be surprised. Okay, so you need to be smart. Not only smart, speed is very, very important. Time is the essence. Okay, you need to be skillful, systematic. Okay, DRS ability, follow the rules. Okay, treatment algorithm, and last is self-sufficient. All right. Okay. Thank you very much. Sorry if if my discussion is too long. Okay. So I open for questions. Sorry, Professor. I don't know how to to reduce my.
It's okay. It's okay. All right. Thank you very much, Prof. Rashidi. That was very intense and informative talk. Okay, it helps to actually update our knowledge on the emergency and trauma management and planning. And as you said just now, life-threatening emergency can be such as sudden cardiac death, and other medical emergencies can occur at any sporting activities at any time. Hence, attending medical personnel need to be very prepared to deal with it. All right. So, all right. Shall we attend to the questions posted to Prof. Rashidi? Okay. First question from Lee. I am a scout and we go for hikes. Usually, we have scout leaders who are trained in BOFA and CPR, usually 2 or 3 in the group. What is the incident or statistic of hiking? Example, like death, accidents in wilderness. And second question, we may not be able to reach EMS support within 1 hour. Depends where and how far we are in the jungle. Any advice?
Thank you very much, Lee. First of all, Lee, I'm not sport physicians. I am a physician. So I can't give you the statistic about hiking death, but I can quote that there are a few incidents. For example, that we have these lecturers from UPM last time, the Mount Kinabalu, you know. So when going down, so he dies. We don't know why. So it can be cardiac, it can be because of snake bite. We're not sure. But definitely hiking. Hiking also is considered as extreme sports for me. For me, it's extreme sport whereby you require desensitizations. You require training. You cannot just hike when you like, isn't it? You need to develop your endurance, something like that. You have to make sure that your heart condition is very, very strong. Of course, in case of this mountain sickness, that is also need to be considered. All right. So that's why when you do hiking, especially the high mountains, okay, you need to have someone that is you need to register. Okay, you need to make sure that you are very healthy, and then you need the guides, for example. And the best is that you have that someone that able to provide at least the first aid. Okay. Okay, now they will not be able to reach EMS support within 1 hour. Any advice? Okay, now as what I discussed just now, number one, the prevention. The thing is prevention is very, very important. Number two is early detections and EMS response. Okay, so if you are unable to get the response, meaning that you have to provide your team. You should not go alone. You must have your team. Okay, so your team must able to provide at least the life-threatening event. So that is advice. So meaning those extreme sport, for example, you should not go alone. You must go with someone with trained personnel, at least the first aiders that able to provide something. And also definitely the importance of the communication system. I think in overseas, I have a friend that he and his wife love hiking, okay, climbing mountain, whatever. So they have this walkie-talkie, and then they can get the chopper. I think they've got the system in place. I think that is very, very important. That is very, very important. I believe that one day you all will be like a team that able to provide all those things. Okay, all right.
So meaning that, Prof. Rashidi, the communication must be tip-top. Means that if you are up there, you must have someone at the ground to actually help you during that emergency situation.
Usually, what happens is that the administrations they know this may happen, so that they have like a base. You know, they have a base. Okay, maybe that they have a 3 or 4 bases. I mean, if you have a problem, you can go to the nearest base. You can contact to the nearest base, so they will come. So means they must have the system. So that's why when we were hacking, we must go to the professional group, not by you alone, because these professionals, they have the system. So in case that you have the problems, they have this pre and also disaster. They apply this for us. Okay. Or if you go alone, definitely you don't have that 5S. You don't have that system. You don't have that structures, isn't it? Okay. So my advice is that please hook with these professionals who have that system, because the system, the organization will assist you.
All right, cool. All right, second question. What are the change of commands during a trauma or medical emergency situation?
All right. Okay. Okay. Now, the the chain of command or the command system that well applied, we call it as the incident command system. Okay, incident command system. At the field, we must also have the incident command system. It head by the chief commanders, and the chief commanders together has the advisors, have the secretaries, and there are 4 teams that will help them. Okay, especially those operational service, logistics service, financial service, and also planning service. Okay, so it's well accepted. It started by the fire service in 1994 with, since the event of the California fire. So, and then noted as the chain of this incident command system is very, very useful. In fact, I apply this technique, this incident command system technique in my department, and then so in the emergency management. Management. So you can apply also the similar system at the field. I'll give you an example. At the field, you have medical, you have fire service, and then you have this police, isn't it? Okay, now to make life easy, you can follow regulation from National Security Act 20 ataupun Arahan 20. Arahan 20 is about disasters, but yes, it's about disasters, but the incident command system was highlighted, meaning that the chief commander is the police, meaning that any problem that you have to go to the police, for example, because the change of command, information, and the rest. Okay, so when you have meeting, for example, like let's say that they call us as a healthcare professionals to that event, okay? So you are part, we call it as a medical team, but you also have these fire team and the rest. Okay, so you need to understand who is the chief commanders. You may be under operations, which is under medical operations. So you're answerable to the chief commanders, but you have the power by your own under so-called the operations. Okay, something like that. Okay, this is a very actually is a very interesting topic. Okay, but at least you have the ideas. Please go back and read about incident command system.
All right. Next question from Putra. Is there any new guidelines in preparing a medical coverage of the sports event? How do we estimate the minimum doctor, paramedic, and AED required in the ratio of the athletes and spectators?
All right. Okay. So thank you very much. Yes, I do have the experience when I was asked to cover for Langkawi tour. So once again, you have to do the high rack. From the high rack, then you need to do estimation, or you can use my formula 30, 10, and 1. But if you're really interested about this, I think in my colleague, emergency physicians from Minnesota, they are very good in this. I'll give you example. You can contact Dr. Ridwan. He's the Selangor emergency physician for state for Selangor. So he has many experience, Sukma, all these things. So you boleh cover, boleh tanya dia lah. Kita ni cap ayam je. Kita ni macam tolong-tolong saja. Kita tak jadi hero lah. Kita backup. Okay. But in general, we do understand about how to do an assessment and the rest. Macam mana nak letak you punya kat mana, you punya system detection macam mana. Because masa I buat Langkawi di tour tu, yang bila nak masuk Kelantan tu, so kita kena ni lah, kita kena buat assessment. For example, like yang first few kilometers, itu lagi dahsyat tu, because dia betul-betul tu. So there are a lot of time orang akan accident. So kita kena tengok corner mana, jadi kita kena letak orang kat corner sana, corner sini. Because why? Is untuk detection. So that ambulance dari belakang boleh datang, dari depan boleh datang. So kita kena fikir macam tu. But the program is fail for us, you know. Why? Communication problem. Rupanya bila kita letak kat corner-corner tu memang tak sampai pula communication problem. So yang ni pun you have to check all those things, okay? Because detection, emergency services tu dia kata orang tu dia semua kena cantik lah, senang. Everything must be in order in disaster. Because this will call it as a chain of survival. And ni kata orang tu betul deficiencies, dia akan affect the whole change. Okay, alright.
Yeah. Means that despite you have enough personnel, if communication is not good, then it's also not
yes.
a good
Betul.
Right.
Betul.
Right. Next question from Tam. Is there any book, recommendation, guideline for the medical sports coverage, especially the emergency command system? Any guidelines?
Okay. All right. So basically, spesifik buku tu tak ada. Kami banyak gunakan gunakan Major Incident Medical Management, MIMS, Medical Incident Major Incident Medical Management. Kita pakai gitulah. So you apply lah kan. Dia bagi spesifik untuk marathon, spesifik untuk ni kita tak ada. Kita ada cuma macam general, and the rest is you punya innovation lah. So understand, because the moment you understand, then you have to do your homework lah. What is the trauma, most likely trauma, most likely medical. Jadi you kena tambah-tambah sikit. Only experienced people yang boleh. But the foundation knowledge, you boleh gunakan Major Incident Medical Management System, Major Medical Incident Management System, ataupun you boleh just type to MASH Casualties Management System. You type your MASH Casualty Management System. Okay. Then you can apply. You boleh apply, but of course, qualification. Alright.
It is readily
boleh buat kot.
Yeah. So it means that it's readily available on the net lah, on the internet.
MASH Casualty Management System you boleh dapat internet. MIMS tadi tu you kena pergi courses. Dia macam international courses.
Alright. Okay. Right. Next question. Alright. Next question from Shahrul. Esports is new sports event. Example Sukma and SEA Game. What can we do if athlete collapse in game?
Oh, okay. So very good. So once again macam tadi kita kena apply apa? Kena apply chain of survivor, and also kena apply DRS ABCD tadi kena apply. Okay. For example, for D is danger. There's a patient collapse. Now, is it patient danger tengah-tengah apa tu? Katakan event apa? Event apa boleh panggil kalau ramai-ramai ni collapse. Katakan kalau naik basikal kan, ni lumba basikal ke ataupun collapse, so nanti orang lain boleh langgar semua kan. Jadi so you need to think about this the dangers, okay? The dangers, and then the response. You have to check the response, for example. So kalau patient prone macam mana, so ini kena belajar ni, check response, macam mana check response, check dekat ni. So you can apply DRS ABCD. Cuma like I told you, now you can advancekan the management. For example, maybe you need to use drugs, for example. Okay. So kalau if you are trained, if you are sport physician, maybe masa tu you boleh gunakan extra lah. Because sometimes AV tak boleh buka AV, so you can put this LMB. So you can buat modification. Dia sama juga balance, but you need to have that modification because now you dah ada someone that is expert, and then you dah recognized, you dah certified, they may be able to perform. Another thing that I can suggest ni, you boleh apply cardiovascular resuscitation dekat field. The rest tu kurang sama. Yes, CCR. Okay. Now kalau you ada physician, because the OSA ni, what the recommendation dia apa? 3 kali shock bawa ke hospital. Betul? 3 kali shock bawa ke hospital. Jadi kalau shock dan kita tu mana? Kita makan masa. But if you have the sport physician, then you can go beyond. As long as the VM you shock. Maybe kalau you pandai, you boleh buat double sequential ke apa kan. So you maybe try a lot of things. Ada studies bagi even they start steroid. I don't know. There are other things that you can apply. Alright? Because what I believe now is that we're going to enhance our capability dekat field. Betul Razul? Kita tak macam dulu lagi lah. Dulu ni first aider saja pergi.
We are more.
Yes, now we are talking about we are trained about trained personnel. We are bringing the emergency at the field. That is the idea. Okay.
At the field. Alright. Okay.
Banyak juga soalan ni sekarang.
Alright.
Tak soalan.
Okay. Next question. What are the roles of coach or fellow athletes during an emergency situation? Example like in the changing room or during a training session. How should they act if there is emergency situation like that?
Okay. Alright. Now, in general, when someone collapse, okay, okay. So what we do, we just apply macam biasa. First, we collapse, make sure there's safety. Lepas tu you check responsiveness. Okay. Kalau dia respond ataupun tidak respond. Now, the worry is kalau dia tidak ada response. Because kalau dia tak ada response, probably dia tak ada breathing dan dia tak ada pulse. Tapi kalau dia ada response, you don't have worry so much. Okay, maksudnya kalau dia ada response, okay, tapi dia weak, breathing pun tak kuat, what you can do, put patient at the recovery position. Kalau dia tak ada injury mana-mana lah, then put the recovery position, call for help, people will come. Kalau panas, you sejukkan, whatever. So means patient when someone unconscious tapi responsive is okay. Tapi kalau unresponsive, memang tak okay. Okay, so unresponsive, sometimes dia ada breathing, sometimes dia tak ada breathing. Okay, so kalau tak response, tak ada breathing, then you have to open the airway. So adalah teknik-teknik dia, and then the best is that go for the proper courses so that you know that how to do. Okay, because your what you're doing is very very significant. It's just by open the airway pun boleh, you know, right? Patient tu unconscious, tongue dia fall to the back, then airway obstruction. So what you do? You buat head lift, chin lift ke, you buat jaw thrust pun, you dah boleh open the airway. So at least they won't die because of the airway obstruction. Okay, macam tu, right?
So, Professor D, so mean that if there is only one person alone, so should they attend to the patient, or should they run and ask for help first? Which one should go first?
Okay, sorry. Now, if you think it's a cardiac in origin, okay, and most of the time kita panggil kalau elderly tu dia cardiac in origins, okay, and then now we also understand that kalau sport kebanyakan is cardiac in origin. Tapi kalau dalam changing room, then you have to consider whether it's the cardiac in origin or it's respiratory in origin. Kalau cardiac in origin, first thing memang you need to get help because you need the defibrillator. Okay. But if it's respiratory, then you attend the respiratory first. If not, you sampai dia mati dah. For example, dia choking ke apa. So you kena tengok yang mana satu, whether it's a respiratory or is the cardiac in origin. Cardiac dia is a dia bukan, kau faham, kita nak defibrillator early, itu saja. How you get early tu, then you fikirlah, kalau tak ada memang you kena lari lah. Jangan lari cari defibrillator, cari orang untuk cari defibrillator, for example. Okay. So that's why sekarang ni sistem kita kena have a system. Kalau lah you punya changing room tu is high risk area tau, you need to have this panic punya button. Dia macam dekat mall ke mana ke, dia ada panic button. Maksudnya kalau something happen, you just crank and then connected. Maksudnya kena ada sistem. Just like what I did for UM untuk tempat-tempat yang tak ada doktor tu. So kalau ada someone collapse, kita kat situ telefon nombor ni, kita bagi telefon situ, telefon 777 ke kan, ataupun you panic button, and then where it goes, kita give to security, for example. Seperti ni dia start ada. So they will come with this defibrillator. So once again, system must be in place. Kalau tidak, dia macam what you can do, just hands only CPR lah. Oleh CPR lah sampai orang datang, itu saja tak boleh buat. But it will improve the survival, because to improve the survival there are 4 things. 4 benda yang akan improve survival. Number 1, weakness arrest. Number 2, high quality CPR. Number 3, shockable rhythm. And number 4, rapid defibrillation. Okay. So you need to to address this issue.
All right. Thank you very much, Professor D. I think there's a lot of questions actually. However, we don't have enough time, so I think we might want all the speakers to answer all these unanswered questions. Maybe we can reply it through emails or whatever to all the participants who asked the question. Thank you very much for your very interesting discussion. All right, next we have our final expert who will be giving her talk today. She is Associate Professor Dr. Jayanti Kulasegara. She is a consultant otorhinolaryngology, head and neck surgeon. Prof. Jayanti is involved in general otorhinolaryngology with a special interest in pediatric ENT and otology and implantation. And she is a member of the National Cochlear Implant Program in Malaysia. She completed her medical degree from Royal College of Surgeons in Ireland in 2001 and has joined University Malaya since November 2017. Prof. Jayanti has 14 years of experience practicing ENT in Ireland. She completed her fellowship in neurotology in UK and second fellowship in pediatric ENT in New Zealand. She is a part of a few specialized clinics such as Combined Orocranial Maxillofacial Clinic, Combined Cleft Lip and Palate Clinic, Otology Implant Clinic, and Congenital Tracheal Stenosis Group. Her academic duties include coordinator for the Master of Otorhinolaryngology Head and Neck Surgery Program. She is a part of the research and innovation team to develop new innovations in the field of ENT, and she is also the clinical and non-clinical research supervisor for undergraduate and postgraduate students. Prof. Jayanti will be talking on ENT emergency in sports. I would like to pass the mic to Prof. Jayanti.
Thank you very much, Prof. Zul, for that introduction. Sorry, Dr. Alston, the video, it says host is not allowing me to put my video on. Okay.
Can you try now?
No, it says host has stopped
it. Okay. Okay, can you try?
It's not working.
Probably you share the slides on that mic. Okay.
Okay.
Okay, good.
Okay, very good morning, good afternoon now to everyone. And thanks for the invitation to this sports emergency webinar. So today I'll be covering ENT emergencies in sports. So as we go along, there'll be some poll questions just to make it a little bit interactive. And please post any questions in the chat box as we go along, and I'll address it at the end. Okay. So what am I going to cover today? I'll be covering 4 main topics, which is skull base injuries, airway injuries, ear injuries, and nasal injuries. So skull base injuries typically require quite a significant degree of impact for it to occur, and are seen more commonly in sport motor racing accidents, and it actually can cause death in this field. So an example is a Formula One driver. So this is Roland Ratzenberger. He died in 1994 during a Formula One race in San Marino Grand Prix. So skull base fractures can involve the anterior, central, middle, or posterior cranial fossa. 70% of fractures occur in the anterior cranial fossa. So anterior cranial fossa fractures can cause anosmia, which is unable to smell, epistaxis, which is nosebleed, raccoon eyes, CSF rhinorrhea, visual disturbances, double vision, ptosis, and loss of forehead sensation. Middle cranial fossa, on the other hand, causes loss of sensation to the midface and lower face due to the trigeminal distribution. It can cause CSF otorrhea, so that's the brain fluid coming out of the ears, deafness, tinnitus, which is ringing in the ears, facial nerve palsy, hemotympanum, where blood collects behind the eardrum, bleeding through the ear canal, or battle sign. So what is battle sign? It's ecchymosis of the mastoid. So you get bruising just behind the ear. It's as a result of extravasation of blood along the path of the posterior auricular artery. So battle sign takes sometimes a day or 2 before it appears after the initial trauma. And it's a sign of middle cranial fossa fracture. So posterior cranial fossa fracture can cause impaired gag reflex, impaired shoulder movement, and tongue immobility. So this is due to cranial nerve palsies. So let's look into more detail the anatomy of the skull base. So the anterior skull base is made up of the ethmoid, sphenoid, and frontal bone. Anteriorly, as you can see here, just use my pointer. So here is the posterior wall of the frontal sinus. This is the crystal gully. So centrally is the crystal gully, the cribriform plate, the ethmoid bone. Laterally is the roof of the orbits, and posteriorly is the wing of the sphenoid. What about middle cranial fossa? So this is the boundary of the middle cranial fossa. So it's made out of the sphenoid bone here and the temporal bone here. Okay, so anteriorly is the lesser wing of the sphenoid, and posteriorly is this bone here, which is the petrous bone. So this is the boundaries of the posterior fossa, cranial fossa. So it's the occipital bone, and here is the temporal bone. So anteriorly, as you can see, it's the petrous bone here. And posteriorly, this is the transverse sinus of the occipital bone. So the foraminus of the skull base allows the passage of cranial nerves. So it's important to know this because when you see a patient who has sustained a skull base fracture, they may have signs of cranial nerve palsies. So depending on the sign, you can roughly tell where the fracture has occurred. So in green is the cranial nerve that passes through the anterior cranial fossa. So you've got your olfactory nerve, your optic nerve, your oculomotor nerve, trochlear, and abducen. So olfactory is for sense of smell, optic nerve is your vision, oculomotor, trochlear, and abducens is for eye movement. The trigeminal nerve, which is divided into three, is ophthalmic, maxillary, and mandibular. It supplies the sensation to your face. So V1 passes through anterior cranial fossa, hence why if you have forehead numbness, you know that there's something going on in the anterior cranial fossa. Okay, so middle cranial fossa, you can get injury to the maxillary and mandibular branch of the trigeminal nerve, the facial nerve, and the vestibulocochlear nerve. So facial nerve can cause paralysis of the face, so it's as though the patient has had a stroke. Vestibulocochlear nerve involves hearing and balance, so they may lose sudden hearing, or they may be they may have imbalance. In pink, you have your glossopharyngeal nerve, vagus, accessory, and hypoglossal nerve. So this passes through the jugular foramen and the foramen magnum and the hypoglossal canal. So as we seen in previous slides, the glossopharyngeal vagus is involved with swallow and voice. Accessory is your shoulder movement, and hypoglossal is your tongue movement. So all these nerves can get damaged in skull base fracture. So let's do a quick poll now. So I just want you to tell me what sign does this patient have? So Elston, can you run the poll? So A, raccoon eyes, B, battle sign, C, Hannibal sign. So I'll give you 10 seconds. Excellent. So all those who answered raccoon eyes, you're correct. So what is raccoon eyes? Is periorbital ecchymosis. So this is due to anterior skull base fracture that can tear the meninges and cause the venous sinuses to bleed into the arachnoid villi and cranial sinuses. So in other words, blood from skull fracture seeps into the soft tissue around the eyes. So raccoon eyes may be accompanied by battle sign, which is the bruising behind the ear. And as I said before, this signs sometimes can appear 2 to 3 days after the injury. So these patients are advised not to blow their nose, not to cough vigorously, and not to strain. So raccoon eyes may be bilateral or unilateral. If bilateral, you can be almost sure, 80% sure, that the patient has sustained an anterior skull base fracture. Okay, we go to our second poll. So what does this picture show? Is it, sorry, this is not the poll. Sorry, Alston, this is not the poll. Sorry, just give us a second. Yeah. So what does this picture show? Is it halo sign? Is it retinal hemorrhage? Or is it sunset appearance? So again, 10 seconds. Yes, so this is halo sign. So all those who answered halo sign, you're correct. So what is halo sign? Now, so this is a sign of CSF leak. So CSF leak is, as I said, brain fluid leaking through the nose. So it can occur in 2% of any head trauma, but it can reach up to 30% of anterior skull base fracture. So 80% of traumatic CSF leak happens within the first 48 hours of injury. So they may, initially they may have CSF with blood stain. So when it touches any sort of paper or bed sheet, it gives this double ring sign, also known as halo sign. And it uses the principle of chromatography, where different components within a fluid mixture, so there's blood or the CSF, as it runs through, say, the bed sheet, it starts to separate as it's traveling through the bed sheet, and it leaves this halo sign. So the sign is not, it's debatable how valuable this sign is, but if you do see it, you should have a high index of suspicion of CSF leak. Other ways of checking for CSF leak is by sending off a sample of the fluid for glucose or beta-2 transferrin. So guidelines recommend that these patients should have a CT temporal bone or CT sinuses, depending on where the CSF is leaking from, to see whether there's any fracture. And a recent review showed that there's actually no evidence to support the use of prophylactic antibiotics in these patients to prevent meningitis. Okay. So before I run the poll, let's have, before we run the poll, 1 second, Alston, I'll just play this video. So look at this child and look at the face. Just pay attention to the face. Okay, I will run it again. Okay, so let's run the poll. What do you think is going on with this child? Is the child got left eye ptosis? Is it a right facial nerve palsy or a left facial nerve palsy? So actually the child has a right facial nerve palsy. So all those, so 30% of you all answered right facial nerve palsy. So that's correct. So let's have a look again at the video. So you can see here, before I start playing the video, the eye on the right is not closing very well, okay? And this fold here is missing on this side, okay? So the motor function is affected on the right side. So there's no movement of the lip. Okay, so this is a right facial nerve palsy. We grade it using the House-Bragman. So how do you know it's a lower motor neuron palsy? The forehead is also involved. So you know that the trauma has happened at the lower end of where the nerve goes from the brain up to the muscles of the face. Okay. So lower motor involves the entire face. Upper motor, which tends to happen in stroke patients, in the elderly, the forehead is spared. So again, this can happen with middle cranial fossa fractures. Okay, so the initial management of these patients is according to the ATLS protocol. So you do a rapid assessment, you treat all the life-threatening problems such as the airway, the breathing, the circulation, and then you look at the glaucoma scale. So you're looking at the eye opening, the verbal response, the motor response. So this is the latest new edition of the glaucoma scale. And we know that if there's been severe traumatic brain injury, your glaucoma scale is usually 8 and below. And also if the pupils are not responding, most likely there's been a fatal damage intracranially, and the patient's outcome is poor. Also, these new guidelines since 2018 states that we should try and avoid hyperventilation, so PCO2 of less than 25 millimeter mercury, and also a systolic pressure of at least more than 100. So what are the complications of skull base fracture? So you can get pneumocephalus, so that's air leaking into the intracranial space, either from the nose or the ear, especially the nose when you use mask ventilation. Okay, so as you're bagging, you're forcing air in, and that can travel in intracranially. The inadvertent intracranial tube placement, so we try and avoid putting anything in the nose because that can go intracranially. You can get carotid artery damage with skull base fractures, hence why these athletes can die instantly. You can get cavernous sinus thrombosis, you can get CSF leak, as I've already mentioned, meningitis, which can happen days or weeks later or even months later, and hypopituitarism. So, as I stated before, skull base fracture commonly occurs in motor racing accidents. So to prevent this injury, many motorsports sanctioning bodies have mandated the use of head and neck restraints, such as this HANDS device. So the purpose of the HANDS device is to keep the head from whipping, forward in a crash, and preventing excessive rotational movement. So it's like a secondary protection without restricting the neck movement. So this was devised by an American scientist in the early 1980s, and is used in many motor racing races. So as I said before, anterior skull base fracture is the most common skull base fracture. And just to summarize, with anterior skull base fracture, you can get contusion of the brain, fracture, mainly involving the frontal bone of the back wall of the frontal sinus. You can get a hematoma, you can get raccoon eyes, and you can get CSF rhinorrhea. So the next topic is looking at neck injury, which can be divided into vascular injuries. It can be divided into aerodigestive tract, and I'll be mainly concentrating on the larynx and trachea. Can be divided into neurologic and others. So due to time constraints, I'll be just mainly focusing on airway injuries, and briefly I'll just touch on vascular injuries. So laryngeal trauma is rare because the larynx is relatively protected okay, by your mandible, by your manubrium, by your vertebral body. Okay, so, and there's also this protective reflex. So if something comes at you, the natural thing is to flex your head forward. Okay, it's to any it's like a startle reflex. Okay, so the pattern of injury really varies depending on age and gender. Women are increased risk of subglottic. So your subglottis is just under your vocal cord, and cervical trachea. So the upper trachea is called the cervical trachea. And because why they tend to have a longer neck. Thyroid and cricoid cartilage tends to ossify as we get older. So from 20 years onwards, our cartilage starts to ossify, so they become harder. So elderly patients are at risk of injury to the cricoid and the thyroid. And they can get comminuted fractures, so multiple breaks. Children, on the other hand, because their laryngeal skeleton is very flexible, it's very unlikely for them to sustain any laryngeal fractures. So I want to just, for a minute, try just, if you have a piece of paper by the side of you, just quickly list down for me from number 1 to number 10, the different parts of the larynx. See how many structures you are familiar with. So this is a cross-sectional picture of the larynx. So just quickly jot down as many parts as you can. Okay, so hopefully you can get as many as you can. So the larynx, as you can see, is consistent of a cartilaginous skeleton, and there's intrinsic muscle and extrinsic muscle and a mucosal lining. So this is the mucosal lining on the inside. Okay. The cartilage consists of so this number 7 is your thyroid cartilage. Your number 9 is your cricoid cartilage, okay? And number 1 is your epiglottis. This here is the hyoid bone. So between the hyoid and your thyroid is your thyrohyoid membrane. Between your thyroid and your cricoid is your cricothyroid membrane, okay? So this fold here is your vestibular or your false vocal cord. And this fold here, number 4, is your true vocal cord. And in between your false cord and your true cord, you have a space known as the vestibule, okay? Number 10 is your trachea. So you can get and the injury can happen at any level. And this is how we grade it. It's using the Schaffer-Furman classification. Okay, so injuries range from mucosal hematomas, laceration, which is grade 1, to fractures, which is grade 2, 3, and 4, depending on how severe the fracture. If it's undisplaced, it's grade 2. If it's displaced, is 3. And unstable or multiple 2 or more fracture is 4. And the most severe laryngeal injury is a complete laryngotracheal separation. So you can see here a complete separation, which is grade 5. So this classification clearly depends on the CT imaging, and also when we scope the airway from the top. So as part of the workup, depending on how stable the patient is, so again, as I said, you follow the ATLS protocol, you have to secure, make sure the airway is secured, the breathing is secured, and circulation. And depending on how stable the patient is, then you make a decision, whether we can have a look on the inside using a scope. And if we can, we can then see if there's any deformities, is there swelling, is there hematoma, is there laceration, exposed cartilage, and we can grade how severe the injury is. And that will also aid as to how we're going to manage this patient. So to be, on the field, you may not notice that the patient has any airway injury because on the outside, you may have no signs. So the signs are all internal. So it's very important to look at the signs of what the patient has. Because depending on the sign, then you need to secure the airway. If possible, do not intubate if there's any possible airway injury because you can worsen the airway, and also to avoid a cricothyroidotomy. So just take a moment and think what possible signs on the field you can come across or you have already come across to tell you that this patient possibly has airway injury. So if you can just list in the chat box, and let me have a look. Just give me some examples of what signs the patient might have. Any responders? Choking, yes. Anything else? Any other possible signs? Yes, subcutaneous emphysema. Okay, so let me just, oops, sorry. So yes, so some of these have been answered. So subcutaneous emphysema, it's like a bubble wrap. So when you press on it, you can feel the air trapped under the subcutaneous tissue. The voice, the athlete's voice might suddenly change, might sound rougher or very hoarse, or they might be in distress. There might be funny sounds coming. It's called stridor. So if you hear any sounds such as, then you know, so that's stridor. So there must be some airway injury. The athlete might be coughing up some blood, very tender when you touch the neck. There might be some bruising. So as I said, sometimes bruising takes a while to come up. Loss of thyroid cartilage. So in men, you have the Adam's apple. So if you find that that's not prominent, then you know that there's some injury that has happened to the thyroid cartilage. If the athlete can't lie flat, you know there's some impending airway problem and you need to act promptly. So this is an algorithm published by Paluska and Lansford in 2008. So let's just quickly, I hope it's clear, go through these algorithms. So if you have any of these signs, okay, then you're suspicious of laryngeal trauma. So the first thing is to see if the airway is stable. So if the airway is not stable, then you need to secure the airway. And as I said, you avoid doing intubation. You go on to do an awake tracheotomy. Again, avoid doing a cricothyroidotomy. So you have to go low. Once the airway is secured, these patients are transferred to the operating theater. We do a direct laryngoscopy. We see how severe the injury is. We also look at the esophagus, and we look at the lower airway if possible. Sometimes the patients are taken to theater for the awake tracheotomy. So again, we can do flexi-scope to do the lower airway assessment. And depending on what we see, we may transfer the patient to radiology to do scanning for further operative management. Now, in a stable airway, we potentially can look at the airway on internally. So we pass a little scope through the nose to look at the upper airway from the top and look at the vocal cords, the epiglottis, and sometimes we can get a view of the subglottis. So if there is any mucosa or cartilage disruption, then you know you need to secure the airway. So we do a tracheotomy in the operating theater. If there's a mild abnormality, you potentially can, in this instance, decide, depending on your findings, intubate and transfer the patient to the CT scanner, or if depending on the severity of the abnormality, you may need to do a tracheostomy. If the airway looks absolutely normal, then the patient just needs to be observed. So what are the treatment goals for airway injury? So really is what we're aiming is to preserve the airway, to prevent aspiration, and hopefully some restoration of normal voice. And this restoration of normal voice sometimes can be very difficult. So I'll briefly, as I mentioned, touch on vascular injury of the neck. So if we just run a poll, I just want to see what do you think, what injury, what vessel do you think is injured in this patient? If we just run the poll, Dr. Elston. So is it carotid artery? Do you think it's the vertebral artery, or do you think it's the external jugular vein? So yes, so it is C, the external jugular vein. So why, it's difficult to tell from just one image like this. It's not a dynamic video, but the fact that we have time to take a picture, it can't be an arterial a bleed, okay? And the patient must be stable. You can see the patient is lying there comfortably with the nasal prongs. So it can't be a major vessel in the neck, okay? So patients with vascular injury can present with shock. You can have an expanding neck hematoma. So expanding neck hematoma, that means it must be quite a significant bleed for it to be expanding very fast. Slow expansion is usually a venous injury. The patient can have hemoptysis, hematemesis. There can be a bruit in the neck or a thrill, or there might be unequal pulses, either in the neck or the arm. So these patients require further evaluation radiologically. We do a Doppler ultrasound looking at the vessels, or a CT neck. If you're suspicious of any other injury, we also tend to do a CT angiogram or an angiography to see which vessel is injured in order to determine how we're going to treat this patient. But this neck hematoma potentially can cause airway compromise. So these patients need to be monitored very closely. The expanding hematoma can compress the airway, and can cause an impending airway, and the patient can die. So be very mindful that even though this patient looks quite comfortable, he's just on nasal prongs, the situation can escalate very quickly. Okay, so next is we will go through some ear injuries. So this is, so laceration to the pinna can happen especially with contact sports. Football, rugby, hockey, stick of a hockey can hit the ear and cause quite a significant laceration. So I would advise, any complex pinna laceration or ear avulsion where the whole ear is sort of hanging, or pinna hematoma should be referred to an ENT specialist or plastic surgery. So prior to closure, we need to meticulously clean the wound, remove any debris, any stones or pebbles that's in the wound, and close the laceration. We use very fine stitches, so 5/0 or sometimes even 6/0 nylon to get a good cosmetic result. So with the pinner, the top 2/3 is cartilage, and only the earlobe here has got no cartilage. So any exposed cartilage needs to be covered, okay? We try and avoid debriding any skin, because if you feel your ear, there's hardly any loose skin, any excess skin. So if you debride skin, it's very difficult to approximate the edges and close the laceration. And we don't tend to stitch the cartilage, we just tend to stitch the ear. As you can see here, we go right around from anterior to posterior, and that's how we close the laceration. So please don't forget about tetanus prophylaxis. Make sure that they've had a tetanus booster in the last 10 years. We also inspect the ear canal and the eardrum. Sometimes the laceration can involve the ear canal. If that's the case, we tend to pack the ear canal with ribbon gauze. So I'm going to run another poll. So Alison, if you don't mind putting up the poll. So spot diagnosis. What do you think is going on here? Is it a pinna abscess? Is it a pinna tumor or growth? Or is it a pinna hematoma? Correct. This is a pinna hematoma. So all those who answered pinna hematoma, you're correct. So rugby players, boxers, martial artists, all these athletes are at risk of pinna hematoma. So what happens? The perichondrial blood vessels shear from the cartilage, and blood starts to collect between the perichondrium and the cartilage. So this should not be left. One, because the longer you leave it, the cartilage loses its blood supply. So it causes avascular necrosis of the cartilage. Okay, and this can cause fibrocartilage overgrowth and leading to cauliflower ear. So please refer this patients urgently to us. What do? We make an incision. So you can see here, there's a big hematoma. We make an incision, usually along the helix of the ear. So this is the helix of the ear. And the hematoma is drained, and we put dental rolls and stitch it in place. So if you were wondering about aspiration, aspiration is a quick fix. However, the blood and sometimes the serous fluid tends to reaccumulate very quickly. So aspiration doesn't tend to usually work, okay? But if you want to buy some time, say it's a weekend, you want to buy some time, yes, you can aspirate and send the ENT, send the referral to ENT on Monday. Or most hospitals have ENT, most big hospitals have ENT teams who will be able to see the patients even over the weekend. And how long do we leave the dental rolls in for? Usually for a week, so that the perichondrium sticks back to the cartilage. And we also give them a course of antibiotics. Next is swimmer's ears, also known as outer ear infection or otitis externa. So as the heading says, it's very common among swimmers. It's often brought on by water that gets into the ear canal and remains there after swimming. It creates a nice moist environment that helps with bacterial growth. Other reasons to get swimmer's ears or otitis externa is people putting their fingers and digging their ears, or using cotton buds, or quite common people sticking metal things into their ears to try and dig their ears when it's itchy. So all these things can cause otitis externa. And also cotton buds, anything that you use to dig your ears, can cause damage to the skin of the ear canal, which is very sensitive and quite thin. You can thin it down, and these patients are prone to recurrent infection. So try and avoid digging the ears. Send these patients to us. We tend to clean the ears with ear toilet. You can see from this picture, sometimes the ear canal is so swollen that you can't even get the drops into the ear. So in these patients, we tend to pack the ear with a ribbon gauze, and we leave it there for 48 hours to reduce the edema before using the ear drops. So just use the chat box and a quick spot diagnosis as to what is going on here. Anyone? Correct. Tympanic membrane perforation. Oh, sorry, it's already there. Okay. Sorry about that. Okay. So how do we get tympanic membrane perforation? Sometimes it's a blunt trauma, so a knock to the ear. Sometimes it's penetrating trauma and barrow trauma. So scuba divers, if they go down, if they descend or ascend too quickly, that can as well perforate the eardrum. So I think everyone probably is aware of barrow trauma. It's when there's difference in pressure changes, or air or water pressure changes. You can, this pressure builds up in the ear, and that can perforate the eardrum. It can happen when we are flying in an aeroplane, when we are driving up a mountain, or scuba diving. So the main thing is to quickly assess the facial nerve function. So the facial nerve runs in the middle ear. So sometimes that can get affected. You can get edema from the pressure. And also you can get hearing loss. So anyone that has a blunt injury during a game and says, I cannot hear, you have to take this quite seriously and refer them to ENT. These patients do not require antibiotics. They usually are treated only if there is a discharge coming out of the ears. Otherwise, you just advise them to waterproof the ears, so don't allow water in. And most of these perforations heal within 2 to 3 months. So it does take time. So you have to reassure your athletes to give it time. And only the ones that don't heal, which is about 10 to 20%, we can repair the eardrum using either cartilage or the patient's own tissues. So last one, just fly through it. I'm sure everybody's hungry. So is nasal injuries. So trauma to the nose, as you know, is quite common because the nose is sort of jutting out. So it's the first thing that can get injured, especially when somebody falls face forward or somebody comes with their elbow during a match. And as you can see from here, the top and the one in yellow is your nasal bone, and in peach is the maxillary bone. Everything else, green, purple, is cartilage, okay? So if you feel your nose, only the top and the side bit is hard. So that's bone. All the rest is cartilage, okay? This is just showing the anatomy of the partition of the nose, which is the septum. So again, only the front bit is cartilage, the rest is all bone. So as with any trauma, you do your assessment, again, your ABCs first. If it's only nasal injury and no other injuries, these patients will be treated accordingly. I will go through in my subsequent slides, okay? So nasal laceration. So nasal lacerations can be quite tricky to fix because the nose has a 3D complexity to the shape. Like in this patient, you can see part of his ala. So this part of the nose is called the ala, has been avulsed. So the ala is skin and cartilage. So it's very difficult, because it's to get the support. So with any wound laceration, you clean the wound properly, and primary closure, if it's not possible, these patients will be referred to a plastic surgeon for further management. So again, for any laceration, please always check for tetanus prophylaxis. The next emergency for nasal injury is septal hematoma. So this really can be easily missed. So we have had a few patients where there was a delay in referral because it wasn't identified. So if it's left untreated, a septal hematoma can cause serious complication because the trapped blood, as you can see in this diagram here, can get infected. And there's the veins in the nose, there's no valve, so it can spread very quickly intracranially. So it can cause serious complication. So what sort of sports? Again, it's the contact sports, football, rugby, boxing, can cause these injuries. And these hematomas need to be drained as soon as possible. So again, if you suspect, so if you look at the nose, you see there's bulges, you're not sure, you can actually use a probe and gently feel it. So if it's soft, which is fluctuant, means there's blood underneath the lining. If it's hard, sometimes the cartilage bends like this. So, when you touch it, it feels hard. So then you know it's a deviated septum and not a hematoma. So what do we do? Just very quickly, we make a cut, we evacuate the clot, open up the space so it doesn't recollect. So, and this wound heals naturally. We don't need to close it. And again, we pack the nose, okay? And that is to, again, make sure that the mucosa sits against the cartilage so it doesn't recollect again. We leave the pack in usually for two to 3 days, and we treat these patients with any pack with oral antibiotics. Next complication, it's quite common, is epistaxis, so nosebleeds. Over 90% of bleeds happen at the front of the nose, okay, which is your Kisselbach plexus, okay. Only 10% is due to posterior, which is the Woodruff plexus, which is supplied by the sphenopalatine artery. So anteriorly, you can see it's got a very rich blood supply. These 5 arteries contribute to your Kisselbach plexus, so it's quite common, and it's quite anterior. So any knock to the nose anteriorly can cause epistaxis. But also, don't forget your other risk factors, check for if they have any coagulation problem. Are they on medication that can cause bleeding? Do they have any other systemic diseases that can predispose them to bleeding? So the first thing with epistaxis is your first aid management. So in non-life threatening, you can do your first aid. So the first aid is sitting the patient forward and pinching the nose. So we just run a quick poll. I would like to know How long do you think we should advise the athlete to pinch their nose for? 1 minute, 15 minutes, 3 minutes? What do you think the answer is? Okay. So it depends if you know what the clotting time. So what clotting time is up to 10 minutes, okay, between 2 to 10 minutes. So really 3 minutes. So if you actually pinch your nose, 1 minute feels forever, okay? 3 minutes is going to be a very long time. So we usually advise patients to pinch their nose for at least 2 to 3 minutes. 15 minutes is extremely long. If possible, 10 minutes, up to 10 minutes, okay? But realistically, 10 minutes is a very long time, okay? So realistically, we advise patients to pinch between 2 to 3 minutes, okay? And as I said, you sit the patient forward because you want the blood to trickle forward and not to the back of the throat. Some will drip to the back of the throat, so you hold a kidney dish to advise the patient to spit it out because blood can make them quite nauseous. Pinch the front bit, not the top. It's the front, okay? Again, like I said, up to 3 minutes. You can see here they're applying the ice pack. So ice pack at the back and sometimes on the forehead. And that's just to help further vasoconstriction. So if this first aid is not successful, then the next step is to pack the nose. So you can see in the first diagram here, this is like a nasal tampon with a balloon. So you can inflate it with air or saline. So first thing first is most times when a lot of people come to us with a pack in their nose, half the pack is sticking out and half is in the nose. It's very important to get the entire pack in the nose, okay? The reason why it doesn't go in because you're directing it in the wrong plane, okay? You have to direct it this angle. So horizontal, don't direct it upwards. You can see here it's horizontal, okay? That way you can get the whole pack in. It is excruciating painful when you're putting in the pack. You really need to warn the athlete that this is very painful and try and push it in as much as you can. And then you transfer the patient to the emergency department. Posture packing is mainly done by us. It's it's done in layers. This is just to show you how it's done. So again, it's done horizontally and it's layered on top of each other. This is a Foley's catheter. This is to put pressure at the postnasal space. Okay, final slide and final poll. So this is a patient, as you can see, has a deviated nasal bone. When do you think we should manipulate the nasal bone? Should we do it day 1, day 3, or day 10? So it's usually around day 7 to day 10. Okay, so day 10 is the answer. Very rarely, patients at the scene, if it's a really obvious deformity, and you are confident doing it on site, on the field, you can do it almost immediately. But most times it's very difficult to tell, because of all the swelling. Because of all the swelling, it's very difficult to tell whether the nose is deviated to the right or is it deviated to the left. There might be, like this patient has a laceration, there'll be some epistaxis, there'll be bleeding from the laceration. So most times it's not possible to reduce the fracture on site. So these patients, you just manage, the acute things, which is the laceration and the epistaxis, and refer to our clinic 7 to 10 days after the injury. So why? Because we want all the edema to settle down. Then we can properly assess how bad the deviation and whether it actually needs manipulation under local or general anesthetic. And most of the patients, we actually stopped doing plain films because it's of no use, because it's more a clinical diagnosis and a clinical examination to see how bad the deviation, to determine if the patient needs manipulation. So imaging is if you're doing imaging, CT is preferred, and it's more for patients with more than one injury, where you're trying to assess multiple fractures. So for undisplaced fracture, patient is happy with the cosmesis. You can feel that the bone is still in place. Those patients, you just have to advise for no contact spots for 6 weeks. So like any other bone in the body, it takes about 6 weeks for the bone to heal. So they should avoid any contact spots for 6 weeks. For this patient, he opted for manipulation. So we literally spray some local into the nose, inject some local on the outside, and it's done in the outpatient clinic, and literally push the bone into place. And we leave that for about 6 weeks. We see them back. And if they're still unhappy with the cosmetic outcome, then these patients would go for more definitive surgery, which is a septorhinoplasty. So that brings me to the end of my presentation. I'll be happy to answer any questions. Thanks.
Thank you very much, Prof. Jayanti. It was very exciting to know more about these unfrequently discussed areas. Injuries to ENT areas can complicate athletes' breathing, sometimes can cause persistent bleeding, and even deformity to the ear and nose, which can be an issue to the athlete later after the injury. For that reason, detecting the complication of ENT injury is indeed very important. Okay, we have a few questions addressed to Prof. Jayanti. Okay, first question is from Shahrul. Can e-sport athletes get the ear injury, and what the symptoms? Maybe because of wearing the headphones.
Yeah, it's because it depends on what type of headphones they're using. So you have 3 types of headphones. You have the ones I have now, it's over the ears. You have on the ear headphones, and you have the earbuds. So depending on what headphones they're using, so if the ear is exposed, yes, you can get injury, and tends to be pinna injury or any blunt force. So any blunt force now over my headphone can cause a perforated eardrum as well.
All right. Okay. All right. The next question: is there anything to worry if young athletes sustain a nasal fracture in comparison to adult athletes?
No. I think there's no difference. Fractured nasal bone is a fractured nasal bone regardless of age.
Right.
The only outcome is to see how bad the fracture is, how undisplaced or displaced it is, and any laceration over the nose.
Right. So age doesn't play any role in terms of in this nasal fracture. Right. Next question from Wazian. Most of the investigation or management of ENT injury need to be done at the hospital. How about beachside care for ENT injury?
So mainly is so for skull-based fracture, thing is your ATLS. Okay, is to secure airway. So you can't really do much. You try to avoid putting anything in the nose. Okay. Neck injury, again, to secure airway. So if you're not aware that the patient has a larynx injury and you try to intubate on site, so that potentially is disastrous. So be aware of these injuries. nose, as I said, most times it can wait. Some doctors are quite confident of reducing the fracture on site.
I said, yeah. All right. Okay. Our next question: if you notice a bruise around the facial area following a fast speed ball, what should we do? Is applying ice enough?
You have to assess. Yes, applying ice will help to deal with the acute problem, but you need to check sensation. So especially if the ball has hit this part of the face, potentially can injure the nerve. So if you have numbness, then you know that there's a fracture.
All right.
If there's any tenderness, always suspect fracture.
All
So
right.
these patients should be referred to the ED department for them to do the preliminary assessment before they get referred to either ENT or maxillofacial surgeons.
All right. All right. Okay. The next question: is there any danger if an athlete has repeated cauliflower ear injury?
No danger. It's just it looks awful. It's a cosmetic.
Just more of cosmetic reason.
Yes.
It doesn't really cause any complication in the ear canal. Nah.
No.
All right. Next question from Tam. Regarding pinna hematoma, how quickly should we refer to ENT for the procedure? Do we need to do it at field site? What is the best for pre-hospital care packed with ice?
So pinna hematoma, you can refer the patient that day itself or the following morning. As I said, you can just stick a needle into it and drain the hematoma to buy some time. So that's something you can do on field. Ice pack is also useful just to prevent, to reduce the edema. But how quickly, it doesn't have to be immediate, but at least within the next morning.
All right. All right. Just early referrals. Early referrals.
Exactly.
Right. Next question from Sharifa. In relation to professional or competitive swimmers, what would be the best prevention measures to avoid recurrent chronic ear infection?
Yeah, so if an athlete has had 1 year infection, okay, they tend to be predisposed to recurrent infection. So earplugs, you can actually get earplugs made to fit. It's like the hearing aid. So it's a mold that is made to fit your ear bowl. So this area where it's totally covered, so it prevents water from getting in. So it's really waterproofing the ears as much as you can.
All right. Okay, so we can use that
earplug.
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 Right. So questions from Nurul: is there any rule for steroid use for prophylaxis in case of neck blunt trauma, in case there is laryngeal edema?
Yes, you can give us the start dose of steroids. Again, is to buy time for your transfer to the hospital in a somewhat stabilized patient. So yes, it's useful.
It's
to
useful.
give steroids, yes.
Okay. All right. Next question from Kevin. In non-contact sports, when you see an athlete is having nosebleed, what should the coach or fellow athletes do?
So essentially, the athlete should come out of the field. Okay. Again, your first aid: sit the athlete down, pinch the nose. If you have ice packs around, put the ice packs on the neck, and pinch for 3 minutes. Okay. And subsequently, the athlete should not go back on the field because this can potentially restart the epistaxis.
All right.
So we would advise at least a week of rest.
A week of rest.
Yeah.
All right. All right. Thank you very much, Prajayanti. That was wonderful talk from you. And on behalf of the organizing committees, I would like to extend our gratitudes and thanks to all the speakers for enlightening us with these 3 interesting topics. And I apologize for all the shortcomings encountered during this session. Before we end this webinar, I would like to call upon Prof. Naha once again to address his closing remarks.
Okay, thank you, Prof. Zul. I hope everybody has enjoyed the session throughout for the past 3 hours. There's a lot of updated information, which is actually very useful among us who do sports coverage, or
Yeah.
even as an additional knowledge for some of us. So, which is actually very important if, let's say, we are undergo to some circumstances. May, if let's say we foreseen this kind of conditions that we need to attend. So hopefully, with all the knowledge that being transferred from all the experts, I hope everybody able to gain some information, and who knows, it can be more practical in future for us. I would like to say thank you again to Prof. Jaya. Thank you so much for your knowledge. It's very, very enlightening. Of course, Prof.
Yeah.
Jacob, thank you so much in terms of your dental knowledge, which is actually some of it is we are not familiar with it. So which is actually
Yeah.
very useful knowledge. And
Yeah.
also Prof. Rashidi for your very enthusiastic talk, which is actually very, very very, very helpful.
Inspiring.
Yeah, inspiring. Okay, so again, thank you so much. It's very honored to have all the speakers. So again, and to all, thank you for your participation. This is very responsive, because without you guys, this session won't be successful. So thank you again. Thank you, everybody, and thank you for all the panelists. Thank you so much,
Right.
and have a nice day.
Right.
Bye.
Thanks.
Thank you very much, Prof. Naha, for your kind words. This is the end of today's webinar. I hope that this webinar has successfully delivered the important and valuable knowledge to all of us. And I hope that everyone has enjoyed this session. Okay, I just like to remind that we are going to have another series of webinars on the 3rd April, where we had topics on-field sports emergency, sudden cardiac death, and muscle cramps. And on the 10th of April, we have eye emergencies, sports concussion, and mountain medicine. I hope to see you guys there during the next 2 seminars. Thank you very much, everyone. Okay, Dr. Chong.
Yeah, thank you so much for all the distinguished guests, speaker, and also especially the audience. Before we end, please kindly fill out the feedback form, scan the QR code. You also will receive a post-event email to request to fill out the feedback form. And also for MMA medical practitioner, you can actually scan the QR codes by logging in your MMA event applications, and you will get 3 points out of this webinar. Thank you so much for all the attendees, and we hope to see you again next week. Thank you.